Good afternoon, ladies and gentlemen and distinguished guests. Thank you for joining us today at the KAST-NAMOK Joint International Symposium. My name is Sung-Jin Kim, Vice President for Academic Affairs of KAST, and it is my pleasure to be your moderator for the opening of the symposium. The Korean Academy of Science and Technology, KAST, and National Academy of Medicine of Korea, NAMOK, jointly held today's symposium under the theme of Research in Biomedical Science, how to conduct in better scientific and ethical way. This symposium will be live streamed through KAST's YouTube channel. We hope you will stay with us and enjoy the whole program until the end. This symposium will consist of two sessions. The first session, entitled Scientific Research, will have 5 presentations and discussion. After a quick coffee break, session 2, entitled Biomedical Research Ethics, with 5 sessions and discussion will follow after. Now let us begin KAST-NAMOK Joint International Symposium. It's my pleasure to invite Dr. Min-Koo, President of the Korean Academy of Science and Technology, for his opening remarks. Please give him a big hand.
Ladies and gentlemen, good afternoon to our Korean and Japanese friend, and good night or good evening to Professor Strom, joining from the East Coast of the United States. It is my great pleasure to welcome all of you to the 47th KAST-NAMOK Joint International Symposium, hosted by Korean Academy of Science and Technology and National Academy of Medicine of Korea. My special gratitude to Professor Byung Choi, the chair of this organizing committee, and Professor Tae-Hwan, the president of NAMOK, for their superb effort to organize this timely and very well organized symposium. I also would like to express my warm welcome and the sincere gratitude to Professor Brian Strom, the Chancellor of Rutgers Biomedical and Health Science at Rutgers University, and the former Professor Kiyoshi Kuboda, the University of Tokyo Grad School of Medicine. Today, we hold the symposium on research in biomedical science, how to conduct in better way, better scientific and ethical way. The importance of the good scientific and ethical research in biomedical science cannot be exaggerated, because the research aims to find the cause of disease, effective ways of preventing and curing disease, and promote people's health status. I hope today's symposium offers fascinating insight into scientific methodology and research ethics in bioscience through the discussing on establishing good research infrastructure and facilitating healthcare big data use and significance of ethical norms in conducting good biomedical research. Finally, and once again, I would like to extend my deepest gratitude to all our distinguished speakers for their great contribution to this symposium. I hope that you will enjoy successful meeting in the viewpoint of knowledge of exchange and the mutual collaboration. I also hope the symposium will be remembered as unforgettable moment to all the participants on and offline. Let me now close by wishing you all a delightful and fruitful symposium. My last question: when I don't need a mask, and you give some answer for our symposium. Thank you.
Next, please give a warm welcome to Dr. Tae-Hwan Lim, President of National Academy of Medicine of Korea, for his welcome remarks.
Good afternoon, ladies and gentlemen. This is Tae-Hwan Lim, the President of the National Academy of Medicine of Korea. I am sincerely grateful for opening the 47th KAST-NAMOK International Symposium along with the Korean Academy of Science and Technology. This year we have prepared a symposium with the topic of research in biomedical science, how to conduct in good scientific and ethical way. The KAST-NAMOK International Symposium has been contributing to the development of medical science in Korea by covering cutting-edge knowledge in current scientific issues. I am honored to invite all the experts from Korea as well as from abroad once again this year for the symposium. During the first session, which is entitled as Scientific Research, Dr. Strom, who is the Chancellor of Rutgers Biomedical and Health Sciences, will explain the clinical biomedical research infrastructure in the United States with the cases from the University of Pennsylvania. Professors Seog, Byung Park, Hyesook Park, and YoungJo Lee will follow on to present the importance of scientific evidence of clinical practice, study design for biomedical big data research, and the technology for facilitating big data studies. For the second session, Biomedical Research Ethics, Professor Kiyoshi Kubota from Tokyo University will introduce the trends about the recent biomedical research ethics regulation in Japan. I'm looking forward to a very interesting and valuable lecture from him. Professors Nathaniel Phang, Byung-Soo Kim, Ok-Ju Kim, Hyesook will then continue lectures on the regulations and ethical issues, including privacy protection. I truly think that both sessions will be a great opportunity for biomedical researchers and clinical practitioners to hear about the lively and timely information in the era of big data and fourth industrial revolution. Lastly, I would like to acknowledge the efforts of Min-Koo, the President of the Korean Academy of Science and Technology, Byung Choi, the Director, and all the other members of the organizing committee of this symposium. I hope that the symposium will serve the role of providing the hall of academy where many presenters and participants can share a wide variety of knowledge. Thank you very much.
Thank you very much, Dr. Lim. We will commence the session 1, Scientific Research. It is my pleasure to introduce two co-chairs of the first session. Dr. Yoon-Ok, Standing Advisor of NAMOK, and Dr. Hoguen Kim, Vice President of KAST, to lead the session. Please welcome Dr. An and Professor Kim with a warm round of applause.
We'll start. 저기서 time is earlier than scheduled.
사인을 준다고 그랬어요.
Well, good afternoon and welcome. My name is Yoon-Ok, the Professor Emeritus, Seoul National University College of Medicine, and the Standing Advisor of the National Academy of National Medicine, Republic of Korea, and KAST-NAMOK, so-called NAMOK. It is a privilege for me to chair the first session of this international symposium with the co-chairperson, Professor Kim, on my side. Well, as you know it, the main theme of this session, the main theme of this symposium is research in biomedical science as to the good ways of conducting. In this session, we were 5 speakers, one from USA and the other 4 from Korea. They will talk regarding the methodological conducting viewpoints in scientific research. After each presentation, we'll go to the floor for the very few simple questions or comments, not discussion, for a few minutes. And for the comprehensive discussion, a separated section for 20 minutes as the last one of this session will be open. Well, I'll chair the first 3 speakers. The rest of 2 speakers and the discussion section, the co-chairperson, Professor Kim on my side, will chair. Well, the time is earlier than the schedule, but I'd like to start this session. Well, I would like to invite the first speaker, Dr. Brian Strom, the inaugural Chancellor of Rutgers Biomedical and Health Science, New Jersey, USA. Let me introduce him in brief. His major research interest is in the field of the pharmacoepidemiology. In addition to writing more than 650 papers, he has been principal investigator for more than 275 grants. And prior to joining the Rutgers, he was the founding chair of the Department of Biostatistics and Epidemiology, and the founding director of the Center for Clinical Epidemiology and Biostatistics, CCEB, at the UPenn School of Medicine. Today, we are very fortunate to have him as our plenary speaker. He's going to tell us about infrastructure for clinical biomedical research in the USA, introducing a historical model, CCEB. Well, ladies and gentlemen, would you please warmly welcome him? Dr. Strom?
Yes, can you hear me okay?
Yes, would you please?
Terrific.
I'm looking forward to your presentation is finished within the 25 minutes for the questions and comments for 5 minutes.
Terrific, thank you. And thank you very much, and it's a pleasure to be with you, remotely at least. I'll say good night to everybody here, given the time here in the East Coast of the United States. The topic today is clearly of great importance, and the events of the last year and a half, the pandemic that we all have lived through, and are living through, obviously shows its importance even more. I am, as was introduced, now in New Jersey at Rutgers Medical School, at Rutgers Biomedical and Health Sciences, and I have been there for about 7.5 years. But the rest of my academic career was spent at University of Pennsylvania at the center, founding the Center for Clinical Epidemiology and Biostatistics and the Department of Biostatistics and Epidemiology. And that's what I would like to introduce you to today as a potential model. This slide and the next slide shows the support that I've received through the years from multiple different organizations, National Institutes of Health, drug companies, and otherwise. If you can't see it, there must be something wrong with your eyes. Seriously. What I'll be talking about today is the Center for Clinical Epidemiology and Biostatistics, a structure that we created a few decades ago, and it is still alive and well and thriving at the University of Pennsylvania. I'll give you a very brief introduction to epidemiology as a field, its history of the CCB, the organization, its objectives, its teaching programs, and its research programs. The goals of the Center for Clinical Epidemiology and Biostatistics are as shown here, and they are to develop the underlying clinical research needed to better prevent and treat disease. And really this is intended, CCB is intended as a core resource for clinical research supporting the medical school in doing so. It's intended as a research resource for the School of Medicine to develop new methods for clinical research and to train the next generation of leaders in clinical research. And I hope to introduce you to all these to get a sense of why epidemiology and biostatistics are really core sciences underlying clinical research. First, from a definitional point of view, epidemiology is the study of the distribution and determinants of health and disease in populations. So again, it's the distribution of disease, how commonly it occurs, and the determinants of disease, health and disease, that is the causes of health and disease, in populations, large numbers of people. And the root of the word epidemiology in Greek is the same as epidemic. It is the study of diseases in populations. It's the basic science underlying much of public health and preventive medicine, and most schools of public health have epidemiology and biostatistics departments as their basic science. But it's also the key science or pair of sciences underlying the ability to do clinical research and biomedical research in general. Clinical epidemiology extends the principles of epidemiology to the critical evaluation of diagnostic and therapeutic modalities in clinical practice. So it extends the principles of epidemiology to the critical evaluation of diagnostic and therapeutic modalities in clinical practice. So clinical epidemiology basically bridges between epidemiology on one hand and clinical medicine on the other, basically using the methods of epidemiology to study the content area of clinical medicine. That's in contrast to biostatistics, which is concerned with the development of statistical theory and methods and their application to the biomedical sciences. Now, the department I founded, as you'll hear more about, was the Department of Biostatistics and Epidemiology. My professorship was Professor of Biostatistics and Epidemiology. And so people often came to me and said, "Oh, you're a biostatistician." To me, that was an insult to my biostatistics colleagues. As an epidemiologist, I needed to learn a lot about biostatistics, but biostatisticians are really mathematicians who develop new approaches, new biostatistical theory and methods. As an epidemiologist, we apply those biostatistics theory and methods to answer questions. And as a clinician epidemiologist, a clinical epidemiologist, we use those approaches to study questions of clinical importance. the history of this field at the University of Pennsylvania, one of the oldest universities in the United States, is an interesting one of a series of failed structures. It had one of the country's first schools of public health, which was disbanded. It had a Department of Preventive Medicine, which was disbanded. It had a Department of Community Medicine, which was disbanded. It had an epidemiology graduate group, which was disbanded. And in fact, when I got there in 1980, 2 weeks after I arrived, I met the leader of the epidemiology graduate group, unfortunately doing CPR on her because she had a pontine stroke. So it was then disbanded. We formed a clinical epidemiology unit that I'll tell you about, the Center for Clinical Epidemiology and Biostatistics that I'll tell you about, the Department of Biostatistics and Epidemiology that I'll tell you about, and the graduate group in epidemiology and biostatistics that I'll tell you about. Central to all these is the CCB, the Center for Clinical Epidemiology and Biostatistics. And really key to CCB is it was an an interdepartmental structure, a center reporting to the dean of the medical school, which included faculty from most of the clinical departments. I and a number of us in beginning it were in the Division of General Internal Medicine based on our clinical expertise. But these are just a few of the other clinical areas that our faculty came from: endocrinology, pulmonary cancer, oncology, cardiology, infectious disease, GI, pediatrics, obstetrics and gynecology, dermatology, nephrology, and ultimately we also formed a department of biostatistics and epidemiology that I'll describe, which is where we appointed our non-clinician faculty who didn't fit into a clinical department. So the goal of the CCB was to bridge across all of these different clinical departments and our non-clinical department in order to be able to bring them all together and allow people to collaborate easily. The objectives of the CCB are shown on this slide and the next two slides. Firstly, to promote clinical epidemiology research, both in the community and in healthcare settings, to promote research in biostatistics and epidemiology methods, to serve as an interdisciplinary resource for clinical research throughout the health system, and to educate the next generation of national and international leaders in clinical epidemiology and biostatistics. And ultimately now at the University of Pennsylvania, most of the division chiefs in the Department of Medicine and the Department of Pediatrics were people who we had trained. Other objectives are to foster the practice of evidence-based medicine by teaching clinical epidemiology, biostatistics, and critical appraisal of the medical literature to medical students, house staff, and faculty at the University of Pennsylvania. To promote a population and community perspective throughout our health system, that is the University of Pennsylvania health system. To serve as a leader in disseminating research results and interpreting research to policymakers throughout the United States and to the public, and to serve as a regional, national, and international resource for communities, universities, governments, and other organizations seeking guidance about issues of population medicine, public health, and the epidemiology of disease. To assist us, we formed two major service centers. One of them was the Clinical Research Computing Unit, had about 50 individuals within it. It included an IT group and a project group. And this was a group that was intended primarily to do large, multi-center, randomized clinical trials scattered around the country or around the world, mostly funded by the National Institutes of Health, but certainly some of them funded by industry or other organizations as well, with enormous capacity to be able to do web-based data entry and do large clinical trials as part of that. The other major service center we formed was the BAC, the Biostatistics Analysis Center. This had two components. The BECC, the Biostatistics and Epidemiology Consulting Center. These were people whose jobs were to provide biostatistics and epidemiology advice for free to the rest of the medical school. And the second part of the BAC's effort was to provide project support. So grant-funded support, largely masters biostatisticians doing programming, most commonly in SAS, to support projects of faculty throughout the medical school. Our Department of Biostatistics and Epidemiology was divided into two divisions. It had a division of epidemiology and a division of biostatistics. And in each case, we had people who had primary faculty appointments in those divisions, generally, again, non-clinician faculty. People who had secondary faculty appointments in those divisions. They were often clinical faculty. So people had a primary faculty appointment, perhaps in the Department of Neurology, and a secondary faculty appointment in the Department of Biostatistics and Epidemiology, in the Division of Epidemiology. And then adjunct faculty appointments, people whose primary appointments were outside the university in local industry, pharmaceutical companies, or government. And this was true, again, both in the Division of Epidemiology and also the Division of Biostatistics. The primary objectives of the Department of Biostatistics and Epidemiology, in contrast to the CCB, is to provide an academic home for biostatisticians and non-clinician epidemiologists. So the CCB was primarily for clinician epidemiologists and linked the clinician epidemiologists to the non-clinician epidemiologists and biostatisticians who were in the Department of Biostatistics and Epidemiology. Second major goal is to provide an academic structure designed to support primary research in biostatistics and epidemiology. Third was to support the CCB in providing consultations on issues of study design and statistical analysis for the medical center. Fourth is to work with the CCB in facilitating collaborative research involving clinicians, biostatisticians, and non-clinician epidemiologists. And finally, fifth was to provide training in biostatistics. So our biostatistics training was based in our department. Our epidemiology training was primarily based in the CCB, where we had both clinician and non-clinician epidemiologists working together. But moving on to training, we had two very different foci of our training. We made a very clear distinction between training intended for users of clinical research versus training intended for doers of clinical research. So the first group of people were people who needed to learn how to read the medical literature and interpret the medical literature. They needed to know what a p-value was. They needed to know what statistical power is, but they didn't need to calculate it themselves. The second group of people were people who were intended to do clinical research. One of the biggest mistakes we found through the years, particularly in teaching medical students, was if you teach medical students in the same way as you teach people who want to do clinical research, they completely tune out. They completely ignore it. And the biggest mistake we found in our in the faculty throughout the medical school is while they're in medical school, they learned about p-values and chi-squareds, t-tests and chi-squareds, and that's what they used most of the time incorrectly, because that's all they knew. Better they know enough. The first group were people who are physicians. The second group, if they want to do research, better that they know what they don't know and know that they need to come for help. The second group of people, on the other hand, were people who knew how to do research, and our intent in training them was to do that and to train people who would become successful principal investigators of National Institutes of Health clinical research grants. So our teaching programs included a first-year basic science clinical epidemiology course for medical students, 4 years of an integrated medical student curriculum in development at the time I first made up these slides. It's now well underway. A program we called Bridging the Gaps, Community Health Internship Program. This was an elective program, but a program that a large proportion of our medical students took to give them experiences in community health going into the community. We had many research electives, many international electives, and a Master of Public Health, which was new at that time. These were all programs designed for users of research. These are people who needed to know how to interpret clinical research, but they weren't going to be primarily researchers themselves. That contrasts with our teaching programs for doers of research, which included our 2-year Master of Science in Clinical Epidemiology program, a 5-year joint program, joint MD MSCE program, again, training physicians to be able to do clinical research. One of my mantras often was an MD is not a license to do research. It's a clinical degree. And the teaching we gave to MDs in general with the teaching I showed you here to teach them enough to be able to interpret clinical research. The people who wanted to do clinical research needed more in-depth training. So either our Master of Science in Clinical Epi or the joint MD Master of Science in Clinical Epi, the PhD in Epidemiology program, a joint MD PhD program in epidemiology, master's program in biostatistics, or PhD program in biostatistics. So all intended to be able to train people who really were going to be researchers. The focus of our MSCE program, a unique program at the time that became a national model, and there are dozens and dozens of programs across the country that were copied off of ours. The focus was on performing clinical research. It included didactic training plus guided research, like laboratory people do guided research, under mentoring. The students were all clinicians. Some were medical students. Some were fellows prior to subspecialty training. Most were fellows during or after their subspecialty training. Some were junior faculty, and some were faculty on sabbatical. But all were clinicians, and all were learning how to be researchers as well, doing clinical research. So our goal is sort of as shown here, to take physicians, teach them use of computers as well, so they can, as a clinician doing epidemiology research, they can do better research because they came up with better questions, better research than the typical non-physician epidemiologist, but much more rigorous research than the typical clinician would have. Our tracks in the MSCE program are shown here, include the epidemiology track, health services research track, a human genetics track, a bioethics track, and a patient-oriented research track. The results of the program between 1981 and when I left Penn now 7.5 years ago, we had 62 trainees funded by the Rockefeller Foundation from 13 developing countries, 10 other foreign fellows who were funded independently, 400 US clinicians, and most of those were still performing clinical research in an academic setting. Many of those received federal training grants, competitive National Institutes of Health grants, while still a trainee. The number of new trainees a year increased from 1 a year to 35 a year. And there was 86 trainees still in the MSCE when I left, including physicians, dentists, veterinarians, pharmacists, and nurses. So all clinicians, mostly physicians, but not exclusively physicians. Moving on to our research program, we had multiple different areas of interest research-wise, which of course depended on the faculty who we had in the program. Included was cancer, cardiovascular disease, clinical economics, dermatologic disease, emergency medicine, genetic epidemiology, geriatrics, medical informatics, nephrology, pain management, pharmacoeconomics, pharmacoepidemiology, my own interest, quality of life, radiology, and women's health. So we had a very broad spectrum of different areas of research, all done by clinicians who had expertise in their clinical areas and also expertise in how to do clinical research. We were also very involved in making recommendations from public health recommendations. And these, and the next couple of slides, just show a few of the different national policy issues that we became involved in. Cigarette smoking, treatment of hypertension, dietary recommendations regarding cholesterol and calories, high absorbency tampons and toxic shock, use of aspirin in children, and with that the risk of Rye syndrome, diethylstilbestrol use in pregnancy, and with that the risk of vaginal cancer as well as other problems. Again, DES in pregnancy, progestins in pregnancy, use of Accutane, an anti-acne drug in pregnancy, which ends up very effective for acne, but also extremely effective as a teratogen. Depo-Provera and its availability as a contraceptive. Long-term health effects of herbicides and contaminants. Safety and efficacy of the anthrax vaccine. Smallpox vaccine program implementation in terms of, as the U.S. went to war in Iraq, the concern was whether or not, in fact, there was smallpox and anthrax that were going to be used as weapons of war, and vaccinating our troops and potentially our public for it as well. Other public health recommendations, cigarettes related to cigarettes and lung cancer, birth control pills and stroke and how that varied, of course, different kinds of pills and different dose of pills. Tampons and toxic shock, aspirin and Rye syndrome, diethylstilbestrol and vaginal cancer, progestins and birth defects, intrauterine devices and pelvic inflammatory disease, bendectin and birth defects, occupational exposures, and subsequent illnesses. So we were involved in many different areas, ranging from advising Institute of Medicine, FDA, other major federal bodies. We were involved in a lot of litigation across the U.S. as experts opining on some of these issues. So I'll conclude with the last two slides. One of them is to my data, right or wrong. Central point was really to emphasize, particularly to physicians who tend to be trained based on anecdotes and, in my experience, what they've seen before. The goal is to get physicians to focus more on data, and again, when we're training researchers, on how to generate those data and how to get good results and meaningful results from that. And finally, I'll conclude, and it was so typically brilliant of you to have invited an epidemiologist. So thank you.
Thank you very much, Dr. Strom, for your informative and thought-provoking presentation. Now we will turn to the floor and participants for questions and comments. We gathered already a few questions for you from the participants. I'll tell one by one after your response for each questions. Our first question is, are there any evaluation results of the teaching programs? This is the first question. Dr. Strom?
Yeah, great question. There are many measures of evaluation that we used that ranged both in terms of process structure, process, and outcome in the usual health services research mechanism. Structure was about what courses were given, how many people were in the courses, and so on. Process focused on exams, exam grades, how people did, popularity of courses, and outcomes in terms of publications, grants, people getting jobs, and like a lot was clearly their competitive for federal grants.
Thank you. Well, second question is, what is your advice for activating good scientific, clinical, and biomedical research in Korea?
I think really a key question, a key advice, and I alluded somewhat to it, is really the bridging between clinical medicine and epidemiology on one hand, epidemiology and biostatistics on the other hand. I think epidemiologists are key. Again, I speak as a clinician and an epidemiologist and a clinical pharmacologist myself. Epidemiology is key science, and epidemiologists do fantastic work. But you can do much better epidemiology if you understand clinical medicine. And if you're a clinician, you can ask better questions, and you can be a better researcher if you're also trained in epidemiology. So my recommendation, probably the key thing, is really to bridge between the two. Bridge between clinical medicine and epidemiology to be able to do the best possible clinical research.
Thank you, very good points. A third one is, could you explain how any clinical researcher gets support from or collaboration with the CCEB?
Well, certainly CCB at Penn, or now programs I've developed at Rutgers, are eager to collaborate internationally. We're very involved. And probably the easiest way to establish collaborations would be just to look up the appropriate people on the web in terms of people who have a common interest with what you do, and then send them an email, or feel free to send me an email and I can link you with correct people.
Well, thank you. The last question is, what was the sources of learning budget for CCB?
The sources of budget.
Yeah.
I can tell you the source of budget was not from our school. The school did not provide any funding. We were started with funding from foundations, particularly the Rockefeller Foundation, as I mentioned, the Mellon Foundation, and the Dana Foundation. And then after that, we were supported through the years primarily with funding from the U.S. National Institutes of Health. That was the source of most of our money. We also got money from the FDA, from the Agency for Healthcare Research and Quality, and from drug industries and other industries as well. So depending on who wanted the results of our research, we had support accordingly. Our training programs were supported. The Rockefeller Foundation program supported training of people from developing countries. Beyond that, we had grants from NIH to be able to support Americans who trained with us. People from other countries who trained with us typically came with funding from their own home institutions.
Okay, thank you. And ladies and gentlemen, is there any other questions, comments? Yes. Have we run out the questions, comment? Yes, then. Thank you very much, Dr. Strom. Please give him a round of applause.
My pleasure, and I wish you all a good night and a good meeting.
Well, I'd like to invite and introduce the second speaker, Dr. Tae-Hwan, Professor Emeritus of Internal Medicine at the Seoul National University College of Medicine. He was the inaugural director of the National Evidence-Based Healthcare Collaborating Agents Korea, NECA, so-called NECA, during the years of 2008 to 11. He has been a well-known physician and also researcher at the Seoul National University Hospital in the area of medical oncology, specifically hemato-oncology. Since 2019, he has been the director of the Patient-Centered Clinical Research Coordinating Center, supported by the Ministry of the Health and Welfare Korea. He will talk about the importance of the scientific evidence for clinical practice. Okay, ladies and gentlemen, please warmly welcome him. Yes, please.
It is my great honor to be here. I'm very grateful to the organizing committee of this scientific meeting. Today I'll present importance of scientific evidence for clinical practice. Okay. 진행을 좀 해주시겠어요? 이게 안 움직이는데. 오케이. 예. In medical decision making, many variables are involved. Schematic summary of the dynamics show that there are three main stakeholders. For evidence, medical professionals are mainly involved in the scientific evidence, and the social value issues are of interest to patients and public. The program of medical resource allocation is being implemented by the government through systems and policies. Today I'll cover mainly of the issue of scientific evidence because it is one of the most important factors. Because I am a medical oncologist, as a clinician, I'll present some examples of cancer patients in this area. Okay. Since ancient times, doctors have been working with the patients to solve problems, constantly making decisions such as diagnosis and treatment. Most of the evidence is based on the personal experience of medical professionals. However, the personal experience could be possibly subjective. That's one of the things we consider. Evidence based on the personal experience or belief runs a risk of error if not objectified. A typical example is bloodletting. Under the hypothesis that a disease is caused by bad body fluid, until 18th century, the conceptual approach that removal of the patient's bad blood would cure the disease. For thousands of years, bloodletting has been practiced. However, there was no objective evidence. Meanwhile, in the 18th centuries, through objective clinical trials by introducing control group and mathematical concepts, French scientist Louis suggests that bloodletting did not improve outcome. Since then, many medical scientists have proven futility of bloodletting through additional clinical trials. Now, bloodletting is no longer standard treatment. Since then, as science develops rapidly, such as generalization of pathology examination and discovery of cause of infectious disease, such as bacteria and virus, and introduction of new imaging technologies, scientific verification based on objective evidence has become possible on methods that were subjectively judged previously. The news caught attention of Korean cancer patients last year was not about the new anti-cancer drug development, but about animal antihelmintics. YouTube video YouTube video of US patient diagnosed with small cell lung cancer claimed that he had been cured by animal antihelmintics pembendazole, which attended clinical trial at the MD Anderson Cancer Center. While he was attending a clinical trial at the MD Anderson Cancer Center, when pembendazole became difficult to obtain on the market in Korea, even the human antihelmintics albendazole was sold out. However, there was no scientific evidence that antihelmintics are helpful for cancer patients. In the middle of a COVID-19 crisis, former President Donald Trump suggested two things: the possibility of injection of disinfectant to the patient, intravenous injection of disinfectant for the patient with infected with the coronavirus to remove virus. Another his suggestion was late. He said he was taking anti-malarial drug hydroxychloroquine daily to prevent coronavirus infection. Even though it was not proven treatment. Over the last 50 years, there have been more than 500,000 treatments had been announced to have anti-cancer effect, and the actual anti-cancer effect was proven only out of 5,100, 50 to 100 anti-cancer drugs are now widely used. So in other words, out of 1,000, you can get one or two therapeutic agents widely used. The sad story about that is most claims they say they have anti-cancer effect is not true because of toxicity or ineffectiveness. So many scientists research and publish the result, but scientific verification through clinical trial is required to be recognized as a fact that can be used as medical technology. Pharmaceutical companies develop FDA-approved drug. Success rate is 1 out of 10,000 compound. In addition, it usually takes more than 10 years because it needs several steps of clinical trials as well as the FDA review process. Most drugs have two aspects, effect and toxicity. We must balance risk and balance. While assessing the evidence of health technology, efficacy and safety are absolute criteria. The familiar twist claim failing to materialize as fact is when drug being promoted as effective cannot be confirmed by other researchers or prohibitive due to adverse event. Most important indicator for benefit is survival. So survival benefit should be verified. For one example is for breast cancer patient, the group of patients who take chemotherapy, CMF, for 6 months after surgery showed 7-year survival benefit in comparison to surgery alone. So definite survival advantage, we say it is effective. However, because showing difference in survival time is the most convincing indicator, but a long observation period is required. Now, instead of survival benefit observation, various proxy indicators such as response rate is used. In case of anti-cancer drug, how can you say it's effective for cancer patient? The common consensus is it should be in terms of tumor area. WHO criteria is we measure the tumor area before and after. It should decrease. Tumor reduction is more than 50%. And the second term promise is it should prolong, sustained for more than 4 weeks. So in other words, it is difficult to determine there is only transient or temporary reduction of tumor size we cannot say it's effective. So it should be decreased more than 50% and longer than 4 weeks. That's the international promise. However, it is sometimes not easy to measure tumor areas. So instead of measuring tumor areas, we can say longest diameter, one-dimensional, more than 30% reduction, we can accept it is effective. Yeah. Still, it should sustain more than 4 weeks. So it's another recently accepted criteria of RECIST. So now most of the measurements are based on this. So let me show you some actual examples. This 22-year-old university student had a mass on the tongue. So we biopsied and it showed squamous cell carcinoma. So unfortunately, he had tongue cancer. But after treatment with chemotherapy, just one cycle, it's almost gone. And the effect persisted more than 4 weeks. So chemotherapy in this patient was effective. That's the way we judge the effectiveness of chemotherapy. However, most tumors are not located. Previously, I showed you the tongue cancer. You can judge by your own eyes, but most cancers are not located superficially. Most tumors are located inside the human body. So in this patient, it's a still young male patient, so huge tumors are deep inside nasal cavity. We need help from radiology exam like a CT or MRI scan, so we can measure the tumor areas, or we can measure the longest diameter before treatment, after treatment. So before treatment, huge tumors are in there, but after treatment, it was gone. So we can say it's effective. As far as the response is persisted more than 4 weeks, these patients are now free for more than 10 years. In the same patient, another view, sagittal view of tumors are here, and after treatment, it is gone. So we say anti-cancer drug is effective. The other side of the anti-cancer treatment is toxicity, the negative side. So easily you can see skin toxicity, you can see easily with your own eyes. But skin toxicity is just a part of the spectrum. More significant side effects can usually occur inside the body, bone marrow or liver dysfunction. So in there, we just check blood exam or some other things. So this kind of things can happen with anti-cancer drugs. In other area, other than cancer treatment, when I was working in the NECA, there was one ophthalmologist. He argued he was very successful in cosmetic surgery. So hyperemic conjunctiva like this, after his technique of surgery, he was very successful in cosmetically whitening of conjunctiva, he argued. So how did he? So he removed the conjunctiva partially and post-operatively to inhibit vascular regrowth. He input mitomycin C, anti-cancer drugs on the eyes, and he treated. He published his work on SCI papers, and that. But however, there was many claims. There were some side effects. Many patients, something like this. So we investigated his performance. About 20% of patients showed some toxicity, and some of them lost the vision. So, he argued this cosmetic surgery is very effective, but in our eyes, it's too toxic. So that's his argument, but fact is not same as his argument. So in health technology assessment, the safety issue is very important along with effectiveness. To objectify the indicator of side effect, international agreement is it should be reported in this form. Common Terminology Criteria, CTCAE. It was published by NIH NCR, so it's the international consensus. And another way to do is, well, there are several papers. They say some people say it's effective, some people say it's not. There are some arguments. So how do we, harmonize and synthesize evidence? That is the way to do is a systematic review or meta-analysis. So combine multiple scientific studies to prove, to evidence synthesis for the purpose of usually decision-making in many different disciplines for evidence-based healthcare, evidence-based policy or practice purposes. So as a research methodology have been developed, the social consensus has been reached on the quantitation of level of evidence is being widely used. Usually, level of evidence is determined by study designs of clinical trials used for validation. So for expert opinion alone cannot exclude subjective factors. So to minimize the bias, we used to recommend randomized controlled trial. Through this process, evidence-based medicine is settled a dogma in medical field. So medical institutions and public organizations such as NICE of UK or Cochrane Review, this kind of organizations are established many countries. In Korea, NECA, National Evidence-Based Healthcare Collaborating Agency, was established in 2009 for evidence-based medicine policy making. So let me go back to the COVID-19 story. Well, he argued this infectant can be injected intravenously to patients. Or if it is done, the virus may be killed. However, before virus, it may kill the patient. So practical problem is since disinfectants are poison, there is a concern that intravenous injection will kill patient before the virus. Therefore, such an attempt is prohibited regulatory agencies, so cannot be made on a human body. Next, he argued hydroxychloroquine. Well, many clinical trials have been published whether hydroxychloroquine is effective or not. Some studies showed a claim they are effective, but other studies do not prove their efficacy. So to make a conclusion, systematic review and meta-analysis have been done by several researchers. In this study, of 1,900 database were screened, and among them, 21 studies are included for final analysis. The analysis of association between hydroxychloroquine and short-term mortality in COVID-19 patients showed no significant difference in comparison to control groups. So in conclusion, in this paper, hydroxychloroquine lacks efficacy for inpatient patient short-term mortality. There was no difference in reducing short-term mortality for hospitalized patients. But in addition, for outpatient patients, the risk of hospitalization was not reduced by hydroxychloroquine. So in this context, hydroxychloroquine is not approved by FDA. So today I summarized my presentation. Scientific evidence in medical decision-making should be objective and be balanced between risk and benefit, and should have high level of evidence. So claims are not always facts. Unverified medical information is causing confusion or unnecessary pain rather than helping patients and their families. So to minimize such unnecessary confusion, objective verification through evidence-based medicine is required. Thank you very much.
Thank you. Thank you, Professor Her, for your excellent and instructive presentation. Now, the floor or participants is open for a few questions. Are there any questions? Yes. May I ask very simple one questions? Dr. Her, could you show us some examples of non-scientific evidence-based clinical practice in Korea?
Well,
could you show us the example?
Yeah.
Yeah.
Yeah, I'm working in the oncology area. There are so many things over there. So every year, one by another. So some people say this one is effective for terminal cancer patients. So if it isn't proven not true, another one is emerging. So it's evolving, especially in the area of herbal medicine. I'm not sure how the government is funding for herbal medicine for the patients. Is there any evidence? I'm not sure. Yeah.
Thank you. Any other questions or comments? Yes. Then thanks again, Dr. Her. Let's give him a round of applause here. Now, I'd like to invite the third speaker, Professor Byung Park, Professor Emeritus of the Seoul National University College of Medicine, and he is current Vice President of the National Academy of Medicine Korea, NAMOK. He has been well-known epidemiologist and renowned pioneer of the pharmacoepidemiology in Korea. He published more than 380 papers. He was the founding, the first and second president of the Korean Society for Pharmacoepidemiology and Risk Management in years of 2007 to 11. And he was the inaugural director of the Korean Institute of Drug Safety and Risk Management, KIDS, for years of 2012 to 15. Well, he will tell us about study designs for biomedical research using big data. Please give him a warm welcome to him.
Thank you, Chairman, for your kind introduction. It is my great honor and pleasure to have an opportunity to give my presentation. Actually, I prepared the recorded slides because I don't have my confidence for keeping my presentation time in 20 minutes. So, could you start? Thank you, Chairman, for your kind introduction. 녹음이 잘 안 된 것 같아요.
Please check the voice. There's no voice.
Validity of study has two aspects. One is internal validity and the other is external validity. Internal validity is defined as degree of bias-free conclusion by the study, which was influenced by selection bias, information bias, and confounding. External validity is defined as degree of representativeness of the study sample. Selection bias stems from an absence of comparability between groups being studied. Information bias can be influenced by the imperfect information from the study population. Compounding occurs when the observed result between exposure and disease differs from the truth because of the influence of the third variable. The confounding variable is as the factor X associated with exposure variable A and is a risk factor for disease B. This slide shows the summary of classification and characteristics of study designs. The observational study and experimental study, and according to the causality level, hypothesis generation and hypothesis testing, and validity level. The result of each study design has hierarchy of evidence according to the reasoning power in causality, but the accessibility is the reverse direction. The 21st century is called as era of big data. Gartner said big data is the new crude oil of the 21st century, and McKinsey said big data is the next frontier for innovation, competition, and productivity. The big data in healthcare field has also drawn attention from the major medical journals, including JAMA and Nature. Big data has the potential to transform healthcare, including predicting disease outbreaks, preventing diseases, cutting medical costs, and improving overall patient care. And the new term, preventive health care, is regarded as the big data's rising role, and using big data to predict and improve your health. According to the development of big information technology, computerized big data appears in every healthcare field, including claims data, pharmacy data, patient data, adverse event information, and medical record data. In Korea, information technology has developed very rapidly since 2000. This slide shows the examples of healthcare big data in Korea. Health Insurance Review and Assessment Service and National Health Insurance Service provide their database to the researchers. And Korea Disease Control and Prevention Agency constructed Korean National Health and Nutrition Examination Survey data and Korea Youth Risk Behavior Survey data and National Immunization Registry Information System data. And Korea National Cancer Center constructed Korea Central Cancer Registry database, and Korea National Statistical Office constructed Death Certificate database. And almost all hospitals in Korea has their own electronic medical records system. NHIS provides sample data which is representative for whole Korean population. The sample size is around 1 million people, covering periods after 2002. And HIRA provides sample data for inpatient dataset and whole patient dataset and elderly patient dataset and pediatric patient dataset. These sample data are provided through their website of NHIS and HIRA. And NHIS and HIRA also provide whole data. The researchers can analyze the whole data through remote access through internet or directly visit the big data center and on-site analysis can be done. From now on, I'm going to introduce some examples of conducting study using big data by study design. The first one is cross-sectional design. The incidence and prevalence of diabetes mellitus and related atherosclerotic complications in Korea was conducted using National Health Insurance Database. The study results showed the prevalence rate was 8.4%, and the incidence rate was estimated to be 9.7 per 1,000 person-years in Korea. The second example is drug utilization review. Prevalence of antibiotic use for pediatric acute upper respiratory tract infections in Korea was done. Showed there was variations in antibiotic use in pediatrics with URI according to type of medical care institution and also the type of physician specialties. And geographic variation was also shown in use of antibiotics. The third example is polypharmacy. The prevalence and predictors of polypharmacy among Korean elderly using HIRA patient sample data. The polypharmacy was defined as concurrent use of 6 medications or more, and major polypharmacy was defined as concurrent use of 11 medications or more, and excessive polypharmacy was defined as concurrent use of 21 medications or more. The polypharmacy showed big regional difference. The polypharmacy rate ranges from 86% to 90%, and major polypharmacy ranges from 45% to 54%, and excessive polypharmacy percent ranges from 2.6% to 4.8%. Case control study compares cases and control groups and find out risk factors for the disease. The association index is odds ratios calculated as A multiplied B over B multiplied C. The example, the first one is fracture. A population-based case control study was done between proton pump inhibition and risk of hip fracture by use of bisphosphonate. Using HERA database, cases were defined as hip fracture claims for fracture of neck of the femur, protrochanteric fracture, or subtrochanteric fracture. Control groups were defined as no claims related to hip fractures and matched up to 4 controls by age, gender, and osteoporosis. Conditional logistic regression was done. The results showed there was interaction between proton pump inhibitors and bisphosphonate, and also shown dose-response relationship. In interpreting the results, several considerations on bias, including selection bias, information bias, and confounding bias. To improve this bias, the new study case crossover design was developed. In contrary to the case control study, which compares the case groups and control groups, this case crossover design uses only case groups. Applying this design, the first example is stroke. Short-acting nifedipine and risk of stroke in the elderly hypertensive patients was done. The study population was recruited as elderly patients aged 65 and 99 with at least one visit with diagnosis of hypertension. Among them, hospitalization or emergency department visit due to stroke was selected, and then patients with first stroke episode was selected, which was 16,069 patients. The index date was outcome occurrence date, and case period as defined as risk window 7 days, and before 60 days window period, control period was defined as 7 days window, risk window. The conditional logistic regression and also stratified analysis was done. The study results shows use of short-acting nifedipine may be associated with increased risk of stroke in the elderly, especially outpatient group. The adjusted odds ratio was 3.63, and new user group, the adjusted odds ratio was 4.17. The second example is applying acute renal failure. ARF following oral sodium phosphate bowel preparation, and use of non-steroidal anti-inflammatory drugs and risk of ARF among elderly diabetic patients was performed. The third example is applying fracture. Levothyroxine dose and fracture risk according to the osteoporosis status in elderly. Zolpidem use and risk of fracture in elderly insomnia patients. Done. Both study compares exposed group and unexposed group. The association was calculated as relative risk in two groups. The incidence density among exposed cohort over unexposed cohort. The example, the first one is risk of intracranial hemorrhage in antidepressant users with concurrent use of non-steroidal anti-inflammatory drugs. Nationwide propensity score matched study. Population was defined as patients who began receiving antidepressants for the first time without a history of having received a prescription for antidepressants during the preceding year. Exposure was defined as combined use of antidepressants and NSAIDs. Outcome variable was defined as intracranial hemorrhage. By using Ewha database, the patients was recruited as defined. The 7.5 patients. Among them, patients without prescription history of antidepressants within testing 1 year, new users was 5.8 million people. The overall cohort was divided into two groups. One is antidepressants and NSAIDs combined group, and the other is antidepressant alone group. After propensity score matching, the two group consists of 2 million patients each. The hazard ratios was estimated 1.6, adjusting for confounding variables. The results was combined use of antidepressants and NSAIDs was associated with an increased risk of intracranial hemorrhage within 30 days of initial combination. The improved study design from cohort study is self-controlled case 3 studies and self-controlled risk interval studies. Self-controlled risk interval studies is specifically developed for vaccination safety. The example of applying self-controlled case series study is cardiovascular safety of methylphenidate among children and young people with attention deficit hyperactivity disorder. The relative risk was calculated incidence density among shadow period, exposed period, over unexposed period, white period. The dot is event. The results showed the increased risk of arrhythmia was observed, and the risk was highest in the children who had congenital heart disease. The self-controlled risk interval design was applied for human papillomavirus vaccination safety. The study design applying two, as one is primary analysis as cohort design, and secondary analysis applied as self-controlled risk interval design. The results showed more than 500,000 doses of HPV vaccines. No evidence was found to support an association between HPV vaccination and serious adverse events in Korean adolescent girls. Strengths of using database compared to real-world study includes more representative samples, less information bias depending on recall or interview bias, ethically more sound, and use shorter time and lower cost, more applicable to rare diseases due to large sample size. But weakness is also existing, which includes lack of detailed information on exposure variables and validity of diagnostic cause is low, and lack of information on confounding variables. In summary, scientific evidence generation for good clinical practice is very important. and healthcare big data have been constructed rapidly due to ICT development in Korea. And valid biomedical research can be conducted using healthcare big data with less time and cost. So, educating the concept and methods of conducting good scientific research using the healthcare big data should be activated. Thank you very much for your attention.
Thank you, Professor Park, for your educational and insightful presentation. Well, only one question was raised for your presentations. I tell you that the questions. The term of big data has been most familiar with the researchers. However, the definition or concept used may not be same between researchers. Well, could you let us know the definitions of the big data?
Yes, thank you for your question. Originally, the big data was defined as 3V: large volume, very velocity, speedy, and variety. And then the definition expanded to add fourth V, value. So now we are using the big data as 4V. So actually, I'm using the HIRA database and National Health Insurance Service database. Is that the exact meaning of based big data? Some did not agree with that. But I think our HIRA database is very big. So volume and very rapidly accumulating the patient information and velocity and also the variety of the information. So we can produce our value in healthcare decision making. So I think it can be regarded as the big data.
Thanks again, Dr. Barr. Let's give him a round of applause. Yes.
Thank you very much.
Yes. Now I'll turn the session over to my co-chairperson, Professor Kim, on my side. From now on, he will chair.
Thank you, Professor An. We are very fortunate in the first three speakers kept good time for us. The next lecture will be presented by Professor Hyesook Park from Ewha Women's University, Seoul, Korea. It is a privilege for me to introduce Professor Park as a speaker. Professor Park is a professor of preventive medicine. And actually, Professor Park started her career as an assistant professor in the Department of Preventive Medicine in Ewha Women's University. And she is served as a research chairperson of the Korean Society of Epidemiology and Affairs of Korean Public Health Association. She received many awards, including the Ministry of Health and Welfare Award. The research field of Professor Park is life course epidemiology and burdens of disease in Korea. The title of today's talk is How Are Linkage Studies Conducted? Please welcome Dr. Park with big hands.
Thank you very much for here as a speaker of the KAST-NAMOK Joint International Symposium. I'm Hyesook Park from Ewha Women's University of Korea, and I'd like to talk on how are linkage studies conducted. The research environment in healthcare, including precision medicine, the fourth industrial revolution, and the passage of the three data-related acts, has changed, creating a new foundation for organically connecting data. By bringing together different information about the same person or entity to create new and rich data sets. Data linkage enable you to study more about different outcomes than existing studies. In epidemiological studies, the types of linkage may include linkages between individual data and group data, and between different sets of individual data. Linkages between individual and group data are relatively easy because there are no privacy issues, while linkages of individual data require personal identifiable information, which is problematic. Although there are concerns about privacy because the connection with personal data is linked to personal identification information, but it can be linked with the pseudonymous processing method. In this presentation, I will look at linked data resource in Korea and point out what should be considered when conducting linkage studies. The first source is Korea National Health and Nutrition Examination Survey called KAST-NAMOK and cause of death data. Based on the 2007 to 2015 National Health and Nutrition Survey data, it is released as one data and combined with Statistics Korea on the cause of death data. The KAST linked cause of death data were provided through the KDCA, Division of Health and Nutrition Survey, and Statistics Analysis Lab, after reviewing the research plan. The specific procedure is shown in this figure. Here is the result for percentage of linked subjects. As of 2020, linkage rate was 97% for those aged 19 or over. The KAST data is a cross-sectional survey, which makes it difficult to identify the causal relationship between chronic disease and risk factors because of temporal relationship. But linked data can compensate for these limitations. However, as the follow-up period is not yet sufficient, analysis of the cause of death is currently possible only for some disease, such as neoplasm, heart disease, and cerebrovascular disease with more than 100 deaths. The next source of linkage is Korean Genome and Epidemiology Study called KOGIS and Cause of Death Statistics. The KOGIS is a data that combines various codes and links gene environment information. This figure shows the start and follow-up period by code from 2001 to 2019. The procedure for applying for KOGIS data and providing data linkage with the cause of death is as shown in the following figure. After the Center for Genome Science of the KNIH reviews and approves the application for data use, the same procedure is followed for data linked to the Statistics Korea NBIS. The linked data is applied for export through the remote system, and the research is conducted with the exported analysis data. This figure shows the number of subjects when KOGIS and the cause of death statistics are linked as of 2015. 6,387 deaths were identified among 215,113 KOGIS participants through data linkage. About 44% of the cause of death were cancer, and heart disease and cerebrovascular disease were accounted for 8% each, and hypertensive disease was about 0.8%. By linking the causes data and the cause of death data, it became possible to analyze the risk factors of death by disease in earnest. The following is NHIS and cause of death statistics. In NHIS, there are various code data, such as sample code, health checker code, and customized data requested according to the research purpose. These data can be linked with data on cause of death. The procedure for linking NHIS data with cause of death statistics is similar to the previous source. For health insurance data, it is necessary to consider data suitable for the type and purpose of the study in consideration of the characteristics of the claim data. In addition, NHIS data should be linked in consideration of the fact that, unlike medical records, detailed diagnostic test results cannot be known. The last resource is the healthcare big data platform. While the preceding data are linked only to cause of death data, this platform can link data from the KDCA, the NHIS, and HERA, and the NCC. After the pilot project ended between 2018 and 2020, the operating system is currently undergoing reorganization. The healthcare big data platform process is shown in this figure. In May of this year, the NCC published the result of the first case of pseudonymizing healthcare big data. The NCC database, NHIS database, and the cause of death statistics were combined to predict mortality trends and mortality in lung cancer patients. When researching with data linkage, I followed the stage of research on what to consider. The big data platform suggests that the first basic principle of using linked data should be in line with the public interest. Here is an example for this. Most epidemiological studies think that the public interest part will be satisfied. When selecting a data-linked research topic, consider that information is open to the public. Therefore, it is necessary to check whether there is any redundancy in the research topic other than final criteria, feasible, interesting, novel, ethical, relevant, when selecting the research topic. It is also important to explore materials that can be linked. It is necessary to review the availability and scope of support for data linkage in advance and review the requirements of each institution. As with the following causes example, even if data is collected by an institution, it may or may not limit its variable, depending on whether it is disclosed or not. Also, an important consideration is the sample size. As the data is linked, the number of subjects from the original survey decreases. In particular, since the follow-up period is rather short for linking death data, so the case of death is small, limiting the type of disease to be analyzed. Linkage data is mainly secondary source. When planning data analysis, it is necessary to review the collection system of each data source and the accuracy of the data. For example, the data from the NHIS may be treated and examined based on the claim data, but the result of the test may not be known. In addition, the definition of a patient is different for each data, such as the K-enhance, COGES, and the NIHS, so review is necessary. The most practical consideration are the duration and cost. For data linkage, a considerable research duration takes several months because the research itself goes through the IRB, data linkage application, and institutional reviews. A research plan should be made with this in mind. When analyzing data, it may be necessary to validate the definition of each data. It should be compared with publicly available statistical data to evaluate the validity of the calculated result for the newly constructed data source. In addition, when exporting analysis results, the result with the risk of being identified the person could not be exported. So it is necessary to review the data export standard. This example compares the incidence of digestive cancer according to disease definition in NHIS sample cohorts and NCC, National Cancer Registry data, to evaluate the validity of the research method. There are differences in the result of age groups by data source. When reporting the research result, it is necessary to mention the main results of the research as well as the disadvantage, considering the characteristics of the data and considerations for interpretation. In summary, through the revision of the 3 Data Acts, pseudonymous information was introduced. This can solve the problem of personal information, which was the biggest obstacle to data connection in the healthcare field. Data linkage research provides opportunities for diverse and rich research, but in order to generate high-quality evidence, it is necessary to understand the characteristics of the data source well and plan the research by reflecting the above considerations well. Thank you.
Thank you, Professor Park, for your very informative lectures. Is there any questions or comment from the floor? If there is no question, so I think the lung cancer data from NCC is very interesting, but the prognosis of lung cancer is very improved in recent days. Is there any data of the past? For example, 10 years before, the survival data of lung cancer for the comparison of the other disease in the 10 years before?
Frankly, I'm not major in the cancer epidemiology, but for this presentation, I prepared and I read the data linkage, and I found they announced the first case of big platform data linkage. They used the NCG and NHIS and Statistics of Korea, and they combined 3 data sources, and they use for the lung cancer patients, but as then I don't know exactly.
Okay, once again, thank you very much for your very excellent lectures. Please give Professor Bach a big round of applause. Yes, our session is progressed very smoothly. The last lecture will be presented by Professor YoungJo Lee. It is of great honor for me to introduce Professor Lee as an invited speaker. Professor Lee is Emeritus Professor of Seoul National University and Endowed Chair Professor of Department of Data and Knowledge Service and Engineering of Dankuk University. Professor Lee has started his scientific professional career in the Department of Statistics at Oregon State University and moved to Oklahoma and Harlem University and finally Seoul National University from 1994 to 2021. He served as the president of Data Science for Knowledge Creation Research Center during the 2012 to 2018. Professor Rees has introduced hierarchical generalized linear models, and his research interests are application of hierarchical linear models. The title of today's lecture is Technology for Facilitating Big Data Studies. Please welcome Professor Lee with big hands.
Thank you very much. It's my great honor to give a talk in these particular occasions, and I'm also very happy to see Professor Yoon-Ok and Byung Park, because when I came in 1986, I collaborate with the EP department to introduce generalized linear models, and then I think now recently, last 20 years, I have been visiting professor and also adjunct professor at the medical epidemiology and biostatistics in Karolinska Institute, Sweden. So in some sense, I was a little relevant in biomedical studies, I hope. And previously, I thought this talk is generally for the general audience, so that I thought before my talk, there is somebody in computer science department is also introducing some technology. And now, today I realize all my previous talk is from medical discipline, so I may little change my title. And then I may talk about my personal strategy for facilitating big biomedical data science studies. Okay. Can I go? Yep. Now I think this is the era of big data and artificial intelligence, and then someone say that future belongs to the one who rule the data. So whoever who owns the data has power. That's the now I think we are witness the era that data become a power of studies, not statistics or something like that. So data become more and more important. Now, if you look at this slide, 1960s and 70s, the most important part is hardware, so IBM computer and those things. And then later they say, no, importance is in software. And then they say, no, statistical analysis, analytics. Now I think they say that no, now the most important thing is the data. So data itself become the power of the world, and then this triggered the fourth industrial revolution. And then I want to talk about this a little bit. Okay. So data is arriving in various ways. And then if you look at, this is Fukuyama area, and then if they release atomic waste, then I think we'll observe the huge amount of radiation data surrounding world and how it influences, okay? And second picture is Chernobyl, and then if you look at the disaster become really disastrous because of health. After the atomic, that just crash of that atomic power plant, it was not the real disaster. That after 3 or 4 or 10 years of health problem was a real problem, okay? There are many plants and many things there, and people eat those kind of things and interact, and then this causes all kind of disease. So data is arriving like this, and then I think the first graph is genomic, cost of genomic data, and the other part is my graph for the neuroimage data analysis. And then now recently, one of my colleagues introduced artificial skin for the, and then he can locate skin before the brain so that we can just observe those neuro image. And then they asked me to introduce those analyses through those medical devices. So medical technology or devices become really great in advance. Now, let's talk about the data science. Actually, I was very fortunate that I found machine learning or those areas in Korea. But at that time, we are mainly concerned about software people and statistics and industrial engineers. We are concerned. And then we thought we developed machine learning and those things. And in statistics, we have also domain scientists like medical science. We have biostatistics. But machine learning is actually data mining and those things is basic software and statistics. And then after the financial crisis, we find that we cannot ignore domain science because we have given 40 years of data. And then using those data based on 40 years, try to find all kind of reasoning and so on. But the financial crisis is something like event which may occur once 100 years. So with 40 years of data in experience, we cannot really detect those financial crises coming, so that we realize we need a domain scientist, okay? So that with the domain scientist, data software technology, statistics, and domain science, we said we need data science, okay? Then we can understand what's going on. So we can do the evidence-based reasoning and those things if we cooperate these 3 techniques together. Now, actually, I'm a statistician, so I thought there is just, because when Professor Gino, Vice President of KAST, showed me the program, there is someone who is coming from software department, okay? So I thought computer science technology, I leave to him, and then I will talk about statistics, but now I should explain a little bit all. So from the bottom, we have the IT technology, okay? We need big, large storage data, and I need real-time things, okay? I should compute very fast. Then in the middle, this is statistics. I should find the explanation and what's the causal relationship and testing, and we should give scientific theory and testing and those things. And then the above part is the role of domain science. So here, medical study, medicine should provide the gold using these two techniques. So you should make new technology, new service, or new medical product by combining these three discipline. So that's what is aiming, okay? Now I just decide to give you statistical part, okay? Actually, you heard about Bayesian statistics, and then second is Fisher, and the last one is me and Professor Nelder. 1986, when I come to Korea from America, I find the epi department of Seoul National University, Professor Yoon-Ok is trying to, he went to Yale University for 3 years to learn generalized linear models and those things, which was made by John Nelder here, okay? And then he tried to introduce what is logistic regression and those kind of things, and then I help him to those GLM areas are actually educated in medical school. Now I think everybody now using logistic regression and so on, okay? And now, today I want to talk what he did after GLM, okay? With John Nelder. And then I think the above part is theoretical part, and I do not want to present, okay? Because Bayesian is a subjective inference, and Fisher developed asymptotic present. We want to exact but objective project inference. And then George Boole. I think everybody may know about Boolean algebra. Boolean algebra is Boolean algebra is the one. Boole think logic. The deductive logic itself can be constructed like a machine. Okay, so that he developed Boolean. So deductive logic can be constructed like Lego building. Okay. Now, with Professor Nelder, I find inductive models can be built bigger and bigger, like Lego, by using random effect, latent process. So actually, okay, so let's see what happened, okay? I have just very limited. So now I think the colleague in Karolinska Institute told me that before I should pass away, I should write a book. So I think I write a book about these new things, okay? So that what's going on statistical areas. And then 1986, when I come, there is a SAS and SPSS is introduced in Korea, okay? And GLIM to teach logistic regression. Now I develop web-based software, Albatross Analytics, which can be done what I'm talking today, okay? So that what now we can do to analyze big data, very from dire source. Now one nice thing is John Nelder was in England, now the originator is in Korea, okay? So, and now I am in Dangung University, and I will teach Dankook University epi people about this software, and you will hear about that soon. Now, this is GLM. So this is, when I write a graph, I have a scale. It means you can observe snoring level, okay? And heart disease, occurrence of heart disease. So it is a causal relation. So it is arrow means snoring level is causing heart disease. So if I have arrow-headed arrow, it means causal relations. And then between two observable variables, I want to have a causal relationship is what GLM is handling. Okay? So if you observe the snoring level, you can observe the odds of heart disease. Okay? Now, joint GLM. This is previously, GLM is only for the mean, but now variance is also important, and I want to show the importance. So actually, this is coming from stroke patient in Bundang Hospital, SNU Hospital, okay? Once the stroke patient, stroke occurs, they are coming to emergency room, and so then the problem is the stroke recur again, okay, in the emergency room, okay. So the neurosurgeon try to do everything to find out through computer scientist people and what's going on, okay. Finally, after 3 years, I was in the conducting data science center. They show this graph, and then they cannot find what's going on, okay? So I said, okay, just plot, okay, what's going on. So I show you two patients, okay? One patient is after 69 hours later, he has a recurrent occurs, and the other patient, stroke does not occur, so he stabilized and released from the hospital, okay? Now, how about if you plot the variance? When you find out was the patient who occurs stroke, recurs stroke, has a large variance. So neurosurgeon is trying to watch what's going on the mean of the height of the blood pressure, not the variance of variation of high blood pressure, okay? So once I saw this graph, I find why we are using this variance as the covariate, okay? So now Bundang Hospital, that's what we are doing, okay? So if you look at this graph, this is the patient who has recurred. But if you look at this graph, his variation is still do not diminishing, okay? But if you look at the one who released, he was, after he got a stroke, he stabilized, okay? But anyway, so it means if you look at the variance of blood pressure, we can predict whether within 20 hours early, I can predict whether he will have a stroke again or not, okay? So that's why I'm showing you that previously GLM is focused on predicting the mean. Now I think we should also look at the variance, okay? Now I think using this regression model, having variance as a covariate, we can find, we can identify most of patients who will recur, okay? So now Bundang Hospital people have released this new method to 5 different hospitals, and they are monitoring. Now, I'm also talking about hierarchical generalized linear model is random effect model. Previously, people think random effect cannot be treated as scientifically because we cannot observe because frailty, each patient have frailty, okay? But we cannot observe that frailty, okay? So that for the fixed unknown frailty, we can talk about, but you cannot talk about the random frailty. But if you look at the patient, okay? If you look at the people, when they are born, they have a very high frailty, and then frailty become lower, and then as you aged, his frailty increased, okay? But if you see his behavior, patient behavior, I can predict his frailty, okay? So what I'm saying is random frailty is also subject of scientific medical studies, okay? Now, random effect model was quite widely used, okay? And then what I'm saying is this is just a technical thing is whenever you have a mean and variance relationship, you can have, and then when you have a random effect, then you can do augmented GLM. So what I mean is all of those models is actually composed of GLMs. So I can make complicated models like Lego so each Lego is GLM, okay? And because 1986, we have teaching GLM since 1986 to medical school in Korea. Now, every medical school student know GLM. Now, say that each GLM is Lego. Now, with this Lego, we can build big models, okay? So that's what we can do. So this is leak cancer data, okay? So I think I can just skip. So for example, now I can, because in 1986, when medical epi people asked me to show me disease mortality rate, then I can just show that average, okay? Now I can show the disease mapping of Seoul, okay? Because each area, so for example, now through the random effect, what I can do is, all with the GLM, we can do the inference of a population average. If I give the aspirin to the patient, what's the population average of temperature change, okay? But now what you can do is, if I give aspirin to particular patient, how he behave, so that I can predict for that particular patient, okay? If I can repeatedly measure, give him aspirin and have the data set, I can do the subjective specific inference. So what I mean is, random effect model is inference prediction for the subject specific inference, okay? So that it has better prediction, because it aims for the patient, okay? If I do something, what happened to that particular patient? That's what I want to talk.
Discussion.
So, okay, so how many time I have?
So we are almost we use already time. So can you summarize?
Okay.
Yeah.
So there are many imputation techniques and neuroimages and those kind of things I can show. And then what I want to show is this. With the random effect, what you can do is like this, okay? For example, oh no, I'm sorry. this is lifetime data analysis, so survival analysis, okay? And this is a clinical study. So clinical data, patients are coming, and then we can monitoring him, okay? And the data, and then with the random effect, it is coming from the same subject. So there is a correlation, these two data sets, and then we can have a multivariate analysis. So what I mean is, through random effect model, now I can have a very, very complicated model with a complicated data analysis. I can analyze neuroimage, clinical data, genomic study, and everything from the same patient, okay? So through the random effect, that's the Lego to joining the, So what I mean is, this individual analysis was previously GLM. Okay? Now, through the random effect model, you can have a combined analysis. Now, I handle various models, and then here important thing is square is observable and circle is unobservable things, okay? So we can, in our scientific inference, we can talk about unobservable things, okay? So in Korea, we have like a 체질. Something I don't know how I can say to English, but anyway, that kind of thing is unobservable things, okay? And then we may put that in, okay, if we have some measure. But anyway, so I have been handling many various things, and then I want to show you my final talk is like this. This is some observed, and I have some unknown functions. So this is a functional model I can handle. And then this is unobserved, the causal relationship among unobservables is called structural equation model. And then from unobservables to explaining about the observed thing is a random effect. Okay? If you combine these two, this is, you may see that this is deep learning, okay? So computer people, without knowing what they do, they are using very, very complicated, very, very big model, okay? And know how to learn this one. But the arrow cannot go to from here to there, or arrow cannot go to come this one. Then they don't have algorithm to learn, okay? But what I'm saying is, I can learn all of those models, and I can test for each arrow, like hypothesis testing, but with that big model, it may take a million years, so it's not combined together, okay? But medical people want to know the explanation. I told you random effect model is for the prediction, okay? And then those my previous hierarchical models are for explanation, okay? So that I can test for each by each scientific hypothesis. But it takes real time, okay? And this computer-oriented big data deep learning model is a very, very big model, but may not be identifiable, and that's only for the prediction. And I have the next slide is for genomic studies, but I will skip that. Okay, thank you very much.
Thank you, Professor Lee, for your excellent talk. So is there any questions from the floor? If not, we are slightly behind our original schedule. So now it is time to begin discussion on 5 lectures of this session. But we need some arrangement of stage. After the arrangement of stage, we will continue discussion with all speakers of this session. Please bear with us for a moment. Thank you. Yeah, we are now ready for discussion with the first speakers, and the organizing committee received several pre-questions, but the questions was used in our presentation. Now the real-time question is also be available during our discussion time. So, Dr. Park, Byung-Jo Park, do you have any questions for the topics of other speakers? If you do not have it, I will start that. I have a question for Professor Young-Jo Lee. So your last slide on the disease distribution of Seoul is very impressive. I think comparing the population size, the area extent of Seoul is not so large, but there are so many differences of the disease pattern. My question is, especially the cerebrovascular disease and heart disease, the mortality is quite different from the area to area, especially the north part of the Han River, south part of Han River is different. So why? The question is, do you have any answer for that?
그게
Yeah.
브라드 디지즈 뭐라 그러지? 브라드 디지즈.
So the cerebrovascular disease is evenly distributed in Seoul, but heart disease is...
and we find that accident and heart disease, the north part has more happening, but the 혈관 disease,
vascular
cardiovascular disease is Gangnam area. I think they are rich but old. So that they have, so that's a very exciting findings. Okay, I thought everything is low in Gangnam area because it's rich, but they have.
But even the cancer distribution is very high, very low in Gangnam area, south area.
But
so
vascular disease. So that I think this kind of mapping is very important if we want to have. Heart center in Seoul, then we should do where we locate it. So we need to plot those kind of fittings. Vascular disease, we know Gangnam area is very good.
Dr. Byung-Jo Park, do you have any idea the population, the number of study population is enough? So he might use all the data of Seoul population, is it right?
Yeah, Seoul population is more than 10 million, not so small. But we consider many, several confounding variables comparing the regional difference.
And can I talk one thing?
Please.
Because in this mapping, this is a small area disease mapping, and then we borrow information from surrounding areas. So Professor gave very exciting questions, but the way we have high accuracy is we are having information borrowing from surrounding areas, so that it's quite good in prediction. Thank you.
Okay, so Dr. Ho, so you are the world famous oncologist. So do you think that why the north part of Seoul has so many instances of cancer comparing to the south part of Seoul? No.
I'm not sure because I do not know the basics of the population. You know, it depends because cancer is a kind of aging disease. So it depends mainly depends on the age of the population. So I'm not sure about the fundamentals of the data is validated on that, such aspect.
And Professor Park, do you have any question for the other speakers?
No questions.
If you do not have the Professor Park's data of lung cancer and mortality and the other disease mortality, and the survival of lung cancer 5-year survival is 22.5% is a mean number in recent days of South Korea. The survival rate of lung cancer is 22.5%. So I asked Dr. Huff, if you are
Well,
expert.
it should be much better because there was a changes in pattern in lung cancer because previously smoking and that kind of things are usually affecting squamous carcinoma. It's a very poor prognosis, but recent cases are mainly from the adenocarcinoma, non-smoker. That population is live much longer. So another thing is the introduction of immunologic agent in cancer therapy. It influenced the survival, so maybe much better than previous years.
Dr. Professor Park, do you have any idea about comparing the cancer survivor and the other disease? So if the specific subtype is changed, how can you correct then that factor?
Yeah, in that aspect, I'm curious about the geographical variation. The mortality rate is standardized or not. We have to standardize the age structure or other confounders.
Yeah, standardized.
Oh, yeah.
But I just try to show off because I have many different kind of disease mapping, and I hope now I want to have medical doctors together. We make real graph, okay? So that I need real collaboration now.
Professor, do you have any comment?
Well, may I add one thing for this session? I understand that the key word of this session is scientific research.
Yes.
So I would like to clearly the conceptual understanding of science versus non-science. I'd like to raise the difference between what is the science research, what is the main purpose of the science research. I understand the science research is aiming to the authenticity judgment, true or false, judgment for the true or false, not value judgment. It's very, I think, important thing to understand what is the scientific research. The scientific research is scientific research aims to the judgment of authenticity, true or false, not the value, high or low, or is right or wrong. It's only true or false. So the way of conducting is derived from the principal concept of scientific research.
Yeah, I'm very grateful that our chairman made a real conclusion of these sessions. Is there any questions on real-time questions available? No. Is there any real-time questions we have? Do you have any real-time questions? No. Still, there is no real-time questions. And if not, maybe this is on time, so we will now close this session. I would like to thank all the speakers and all the attendees, and particularly those who stayed to the end of these sessions. We are now going to take a 10 minutes break, and session 2 will be continued after that. Thank you very much. 진짜 근데 되게
All right. Thank you so much for attending the second session on the biomedical ethics. My name is Nathaniel Hwang, and I'm currently a professor in chemical and biological engineering at Seoul National University. And I'm currently co-chairing the session with Professor Chancellor, who's a professor in Korea University of College of Medicine, and who's also the board president in Korean University Council of Research and Ethics. So we have a very wonderful list of speakers today. And from the first speaker is former professor Kiyoshi Kubota, who's a former professor at University of Tokyo Graduate School of Medicine, and who is also currently a president of NPO Drug Safety Research Unit. So Professor Kubota will be our first speaker, and we have three other speakers who will be lining up, and we'll have the question and answer session at the end of the whole session. So please welcome Professor Kubota as our first speaker.
My name is Kiyoshi Kubota. I am former professor of pharmacoepidemiology in Tokyo University, and also former president and the first president from Asia of International Society for Pharmacoepidemiology for 1 year between 2016 and 2017. First of all, I would like to thank Professor Min-Koo of Korean Academy of Science and Technology and Professor Tae-Hwan of National Academy of Medicine of Korea for the invitation. I also thank Professor B.J. Park in Seoul National University College of Medicine, who recommended me as one of today's speakers. It is my honor to give a talk in this important symposium. The title of my presentation is Biomedical Research Ethics Regulation in Japan. This slide shows a figure in a paper in Japanese, published more than 10 years ago. The figure shows that the number of papers on clinical researches published in main international journals from Japan between 2003 and 2007 was smaller than the number on basic research. This reflects minds of Japanese investigators involved in biomedical researches before the 21st century, who considered that basic research was sort of superior to clinical studies. Therefore, the ethics in biomedical researches were also not considered as an important issue. So, clinical studies are relatively new to Japan, and guidelines or legislation for ethics in clinical studies emerged also only recently. But before explaining Japanese situation, I wish to quickly review what makes clinical research ethical first. This is because such a review will help us have a common view on what should be components to be included in ethics guidelines or legislation on ethics in biomedical researches. What makes clinical research ethical is a title of a paper published by Emmanuel, Bendler, and Grady in JAMA in 2000. This paper is often referred in the discussion on ethics in biomedical researches. The authors of this paper raised 7 requirements for clinical researches to be ethical. According to authors, these 7 requirements are listed in chronological order from the conception of the research to its formulation and implementation. Please note that I changed the order of the last two, for number 6 and number 7, in today's talk. The first two were value and scientific validity. The reason why they are related to ethics in clinical research is that risk of subjects is generally not zero in clinical studies, and only studies with value and scientific validity justify exposing subjects to some level of risk. The third requirement is that selection of subjects should be based on the scientific goals. However, they emphasized that subjects who are eligible based on the scientific objectives of a study, but are at substantially higher risk of being harmed or experiencing more severe harm should be excluded. The next three requirements are related to duties of researchers who make sure about favorable risk-benefit balance, because if risk outweighs benefit, the research is unethical, regardless of the subject's consent. They explained that this balance may differ for different contexts. For example, the balance of the risk of interception and benefit from effectiveness of rotavirus vaccine may differ between developed countries and developing countries, where the number of deaths of infants from diarrhea, which is often due to rotavirus infection, is quite different. The next requirement is independent review by ethics committee, including independent data monitoring committee in clinical trials. The sixth requirement is respect for subjects, including privacy protection, accepting change of mind. For example, withdrawal from the study should be permitted without penalty, and new information, particularly new information related to risk and benefit balance, should be provided to subjects in the course of research and giving proper treatment when adverse event occurred. The final requirement is obtaining informed consent. They emphasized that obtaining informed consent is only one of 7 requirements. In addition, in some occasions, the study without consent may be not unethical, like when an unconscious patient is likely to have benefit from new treatment in the emergency. And as explained earlier, even if the subject gave consent, the study could be unethical if risk outweighs benefit. This shows a little different way of thinking on ethics in clinical research is shown in a book published in 2001. In this book, Claire Foster said that there are 3 areas of ethical concern, or 3 moral approaches in research. The first goal-based approach may include requirements 1 to 3 in JAMA 2000 paper and related to scientific goal, or the research should have value and validity to be ethical. The next duty-based approach includes the next 3 requirements in JAMA 2000 paper and is related to the duty of a researcher and doctor who should make sure that risk-benefit ratio is favorable, the study is reviewed by independent review committee, and subjects are reasonably protected. And the last right-based approach is relevant to informed consent, which is patient's right. Costa said that these three approaches may clash or collide. One example is the use of placebo controls in clinical trials, particularly when there is already effective treatment. The need of placebo control is often yes from the goal-based approach, but often no from the duty-based approach. Going back to Japanese ethics regulation, I think a historical review is preferable because the relevant issues are changing during the recent 20 to 30 years. One of the changing issues is people's mind about patient autonomy. And before late 1990s, paternalism prevailed in Japan. Two related symbolic social phenomena are, first, inclusion of informed consent in Medical Service Act in 1997, and second, 2002 Supreme Court decision on doctors' duty of cancer notification to cancer patients. Another change is the development of information technology, which provided a new research tool to investigators. But it was also recognized as a new threat to privacy protection. Guidelines for clinical researches on gene therapy issued in 1994 was one of Japanese earliest ethics guidelines on treatment where genes are introduced into human body. It required informed consent, protection of patients, and review by the government or Ministry of Health and Welfare, MHW. In the original guidelines, consent can be verbal, but this was amended and a written informed consent was required later. From 2002, ethics review in Institutional Ethics Review Committee was judged to be satisfactory, and a review directly by the government was not considered as a requisite. Another early ethics document was Good Clinical Practice, GCP. GCP was first issued in 1989, which was, however, substandard guidelines from the current viewpoint. GCP issued following agreement in ICH, or International Conference on Harmonization, in 1997, required that the clinical trial should be conducted according to the international standards, such as written informed consent, ethics review, monitoring, audit, etc. I may mention that being associated with clinical trials, heterogeneity of regulations or double standard exist in Japan. In North America and the European Union, and probably in Korea, GCP gives general standards of clinical trials. In Japan, GCP gives rules for clinical trials, aiming approval of new drugs or devices called CHIKEN. CHIKEN is normally conducted by industries, but investigator-led clinical trials aiming approval of new drugs or devices was added to GCP in 2003. So far, more than 700 investigator-led clinical trials aiming approval of new drugs or devices have been conducted. On the other hand, non-CHIKEN or non-GCP clinical trials are regulated by different guidelines, but not by GCP. Before explaining non-GCP clinical trials, I wish to explain other legislation and related guidelines which were introduced before the introduction of guidelines for non-GCP clinical trials. In 2000, Act on Regulation of Human Cloning Techniques was enacted, and in 2001, relevant guidelines on specific embryos and human ES cells were issued. And later in 2010, guidelines on iPS cells were issued. Some Japanese guidelines do not have superior law. One of such guidelines are guidelines for human genome and gene analysis research in 2001. This includes requirements for informed consent, protection of subjects and personal information, ethics review, genetic counseling, etc. for researches on germline mutation, which is related to heritable disorders. In 2002, guidelines on epidemiological studies were issued. Need for various types of informed consent was indicated, dependent on whether the study is interventional or observational. Whether or not study uses specimen from humans, whether or not study uses newly obtained information or existing information only. These guidelines also do not have superior law. In 2003, guidelines on clinical research were issued. Though the title of the guidelines included clinical research, guidelines were for interventional studies or clinical trials. Thus, guidelines were actually for non-GCP clinical trials, and written informed consent, ethics review, and protection of human subjects were required, but guidelines were less strict than GCP. For example, requirements for monitoring and audit were not included in the original guidelines, but they were added in 2014 amendment. Those two guidelines for epidemiological studies in 2002 and non-GCP clinical trials in 2003 gave large impact on researchers because many studies were relevant. Those two guidelines stimulated researchers to conduct studies with sound plan while satisfying ethical standards. Long list of questions and answers were made and updated on the relevant website of government, and both guidelines were revised several times, reflecting that the guidelines were actually used in many relevant studies. I think these two guidelines and the exchange between researchers and government worked in a favorable way in that they fostered minds that ethics should be an essential component of clinical researches. Another effect of these two guidelines was that they promoted formation of a number of new ethics committees in universities and hospitals in the nation. Those two guidelines were unified in 2014. In the unified guidelines, for interventional research, requirements of monitoring and audit were newly included. Other new points included were education and training of researchers, as well as ethics committee members, and the management of conflict of interest issues. In 2021, or in this year, One of the earliest guidelines for genome and gene analysis researches, which I explained earlier, was further integrated into 2014 guidelines. Some new points, such as single ethics review for multi-center study and report of study results to study subjects, were added. But the guidelines still do not have a superior law. There are 4 additional guidelines without superior law. They include guidelines on fertilized embryos, animal experiments, and heterologous transplantation. Now, I think that I must mention Diovan scandal. Diovan is a trade name of valsartan and reports of 5 studies to compare valsartan with other ARBs, angiotensin II receptor blockers, were published in Lancet, European Heart Journal, etc. between 2007 and 2011. All 5 studies indicated valsartan was much superior to other ARBs. For example, in the paper published in Lancet in 2007, incidence of cardiovascular events was about 40% lower in valsartan users compared to users of other ARBs. This turned out to be a lie. A company staff member was deeply involved in the study. Publication by a company staff member was found out, and all 5 papers were retracted. The company staff member was sued, but the person was judged to be not guilty, even if publication was recognized in the lawsuit. The reason for not guilty was that this publication was not regarded as deceptive advertisement, which was the condition that the person was judged to be guilty. Around the same calendar time, similar to additional scandals occurred in Japan, and a new law, Clinical Trials Act, was enacted in 2018 as a direct consequence of those scandals. In this law, specified clinical trials were defined for non-GCP clinical trials, receiving funds from a drug company. These specified clinical trials should be approved by Certified Review Board, which was certified by the government, or MHLW. The act is, I think, sort of ad hoc law or temporary measure in emergency. Anyway, clinical trials in Japan are now regulated by 3 different rules, or GCP, Clinical Trials Act, and guidelines without superior law. This is my personal view. I think comprehensive law for public health and clinical researches, like Bioethics and Safety Act in Korea, is needed in Japan. But in my view, what is more important is, as basic conditions, comprehensive planning of structure of the society for public health and clinical researches should be made. This is because many resources in the current Japanese society are fragmental or non-systematic from public health viewpoints. Similarly, many guidelines are also fragmental, and some of guidelines do not have superior law. One example of lack of comprehensive planning of structure of the society is that there was no unique identifier like social security number before 2016 in Japan. In 2016, a unique identifier was introduced, but it has been used mainly in the tax business. Though the government is currently trying the use of unique identifier in other fields, including medical care. Another example is National Claims Database, which collects claims data from 2010. Superior law is law concerning ensuring medical care for the elderly, and Article 16 of this law is said to be relevant. But Article 16 of this law is on the investigation and analysis for planning of streamlining medical expenses, and the use of data for public health and research is sort of expanded interpretation. To be effectively used for public health, some data may be centralized or formed in a standardized way. But this was the case only recently for some of relevant data only. For example, nationwide cancer registry, where personal identifier was included in collected information, started as late as 2016. Before 2016, the identified information was collected in cancer registry. In the last decade, many nationwide registries for various diseases and procedures like surgical operation have emerged, but they are often by a voluntary effort of the individual academic societies, but did not really accord with comprehensive planning. Record linkage between those resources important for public health is difficult and sometimes strictly prohibited. The difficulty may be associated with lack of comprehensive planning, fragmental regulations, people's concern about leaking of personal information, and no unique identifier before 2016. I think people's concern and lack of comprehensive planning is two sides of the same coin. People worry because comprehensive planning does not exist, as symbolized by the fragmental guidelines, sometimes with no superior law. This is a summary. I started quick review on 7 requirements that make clinical research ethical. I then reviewed historically research ethics regulation in Japan. I explained current fragmental status of resources in the Society for Public Health and Research Ethics regulations. I explained recent development of centralized data sources and the difficulties of record linkage. Lastly, I emphasized need for comprehensive structure and law for public health and clinical research. Thank you very much.
Thank you. So we will hold the question until end of the session, where we're going to have all the speakers come up for the discussion session.
Okay, the second speaker is Nathaniel Hwang, who is presiding this session, and he is also presented for this session. He is currently a tenured professor in the School of Chemical and Biological Engineering at Seoul National University. He is a member of the Institute for Chemical Processes and Biomass Institute at Seoul National University. Also, he holds an adjunct position in stem cell graded program and interdisciplinary program bioengineering at Seoul National University. He is currently focusing on the research to develop new biomaterials, study stem cells, and design new technologies for regenerative medicine. Particularly, his laboratory is working toward the fabrication of biosynthetic microenvironments conducive to stem cell differentiation by manipulating scaffold properties, incorporating the desired biological signals. In addition, his laboratory is developing non-viral strategies for direct conversion stem cell technology. He is an active member of Tissue Engineering and Regenerative Medicine International Society and Korean Society for Biomaterials. His presentation is the ethical concerns in regenerative engineering stem cells to humanized model. Nathaniel Hwang, please.
Thank you so much for the wonderful introduction. My name is Nathaniel Hwang. I'm an engineer, but I do work on tissue engineering. So I'm sure many of you are familiar with this area where this whole field began to replace disease or malfunctioned tissues or organs. So the initial idea was to propose where cells or stem cells from patients' own body, autologous stem cells, are isolated, and using a synthetic scaffold and growth vectors, ideally you can engineer tissues in a laboratory setting and transplant into a patient. Okay, and then recently, there has been technique where the decellularized tissues, or tissues from other organs or other animals or other patients are decellularized, where all the cells are removed, and use this biological scaffold for the replacement. And the whole field began, Professor Langer and Jay Vacanti, where I spent 3 years as a postdoctoral fellow. Actually, I've been working on this year project when I was doing, postdoctoral fellow, and they began, whole theme of the tissue engineering using synthetic scaffold and cells and engineering organ. The problem is that, when you're trying to engineer a large tissues, okay, you need to have a tremendous amount of cells, okay? And for example, if you have a cartilage defect like this, okay, and you need to, in order to fill these tissues, you need to have a large number of cells. And one of the ideas is that you can actually isolate, from a non-load-bearing region of articular cartilage, okay, make a small biopsy, expand into GMP facilities and expand the cells and fill them into the, inject them into the defected site, and fill with the, and suture with the periosteel flap. Okay, this was actually a product called the cartilage cells. It was popularized in late 90s, but somehow the production or the marketing has been gone down. Is because when you expand the cells, especially your own articular chondrocytes, they tend to lose their phenotypes. Okay, these, you can expand the cells using, basal media, but then as you passage the cells, what happens is that this phenotype, the production rate of the proteoglycan and collagens of these articular chondrocytes, they lose their phenotype, and they lose their, the gene expression profiles. So they become, even if you have expanded these cells in so many times, enough cells to be transplanted, what happens is that these cells lose their phenotype, so these cells no longer can make the tissue that you want to be. Okay? That's why people, in tissue engineering, the field that we are in, I'm currently in, we have been actually exploring use of stem cells. Okay? One of the great advantages of stem cells is that they can actually self-renew. Okay? Meaning they can be expanded, they can be proliferated without changing their phenotypes, and they can be differentiated into the cells that you want. And when you think about stem cells, at the top, it's a pluripotent stem cells or iPS cells or embryonic stem cells, where you can maintain these cells and differentiate into, probably most of the cell type that our body contains. So there has been a lot of investigation since 2000, and especially in the realm of tissue engineering, we've been actually exploring the use of stem cells, embryonic stem cells, mesenchymal stem cells, other stem cells, to be utilized in tissue engineering. And back in 1998, everyone thought that this guy, Jamie Thompson from Wisconsin, he's going to win the Nobel Prize on stem cells, because he was actually the first one to actually isolate the embryonic stem cell from the blastocyst from human embryo. Okay, was able to maintain them, and was able to supply these cells for the basic research area. And because the cell population is so powerful, okay, you can actually make every type of cells in your body. We thought that this could be a solution for tissue engineering. However, in 2001, 3 years later, George W. Bush became a president. Okay, he enacted a law or stem cell policy where he actually it banned. Okay, the policy was intended as a compromise and specified that research on lines created prior to that 2001 would be still eligible for the funding or federal funding, which is 71 lines from the 14 laboratories across the globe met that criteria. And those who actually made the embryonic stem cell line after 2001, okay, were not able to apply for the federal funding. So some laboratories, this is actually based on the ethical concern. The President of the United States was so concerned about the destroying embryos, and he thought that it's unethical, okay, and unreligious. So he implemented this policy. So people in the scientific field, we thought, if the government is not funding, we can actually get the private funding to support the research. So, people in Harvard University, they actually created another stem cell research facility right next to the existing one with the exact same type of, laboratory equipment, but from the private fundings. So this actually, in 2001, this actually came around, with a huge force on the stem cell field, because, people are trying to isolate and develop a clinical relevant human embryonic stem cell, but there was no funding available. So there were actually people were actually trying to get the alternative ways to use stem cells. So if you think about the ethical concern about destroying embryo, this is actually a paper published in the same year, 1998, with the John Gearhart. Okay, this is actually derivation of pluripotent stem cell from cultured human primordial germ cells. So it's not even an embryonic state. This is actually germline state. After 3 to 4 weeks of gestation, an embryo, you can actually get these, primordial germ lines, and then isolate them and maintain the pluripotent stem cell from these, embryo. But at the moment, this, if you consider this actually human tissue, this is from the aborted fetus. So this was concerned, labeled as a human tissue waste. So you can do whatever you need. Okay, you can isolate the cells, and this was still eligible for the funding. So there's actually discrepancy, in early 2000 regarding the source of and the funding of human embryonic stem cells. So after the policies, I believe these were people were trying to make these pluripotent stem cells. Okay, there were studies in early 2000 using nuclear the cell fusion to get the tetraploid or the double the amount of the fused cell for the making of embryonic stem cells. There's actually direct reprogramming, actually, Professor Yamanaka, and there's several other studies where people are trying to make the embryonic stem cells. And I believe that in 2012, this Nobel Prize winning was much contributed by the previous existing U.S. policy banning, making or using embryonic stem cells, and this led many scientists to actually ponder upon: is it possible to make embryonic stem cell using different technique? And thankfully, Professor Yamanaka succeeded by having 4 factors transfected into the and making an iPS in 2006, where in 6 years later he won the Nobel Prize. But even with the iPS, there's still risk factors. I'm sure previous Professor Kubota, he mentioned the ethical concerns or the regulation regarding the iPS in clinical trials, and we don't know what happens with the stem cell when they inject it into the bodies. Okay, most of cells would die off, but then if there's a benefit, what is exactly the mode of action for this type of cells in the body? Okay, so even as for future clinical trials, we need to have a concern and also the understand the risk factors and approaches of these stem cell-based therapies. So one of the major concerns, okay, regarding the stem cell therapy is that if the cells are injected into the body, okay, these are all these concerns. But one of the major concerns as an engineer, we want to have the cells to be survive, okay, and maintain, okay, and then engraft into our host tissues and do the functions, okay. And one of the so we actually went back into the current cell therapies. And one of the emerging technologies is actually the allogenic pancreatic islet cell transplantation for the type 1 diabetic patients. So it's actually from donor, it's actually diseased patient. Okay, so you can actually make an islet cell from the iPS cells, or you can make from stem cell, or you can make a xenogenic islet cell, or you can even recently make a chimeric human models, okay, on islet cells and transplant into the human body. So it's because many engineers, or the transplant surgeons, they feel that there's a need to do this type of surgical procedure to benefit of patient, okay. But however, when you think about the source of these cells, okay, are they ethical enough to be generated, okay, and then transplanted into the patient? That's something that you need to ponder upon. So type 1 diabetes in the U.S. is about, has 1.6 million patients are suffering. There are about 6,000 new patients every year, okay. And we have, so our laboratory actually has performed to, ways to prevent it. So if you have for example, the islet cell, it can be from xenogenic or it can be from the allogenic sources. One of the drawbacks is that upon implantation into the portal vein through a portal vein, these cells would actually engraft into the portal vein, okay? And these cells, would undergo some immune reaction if they're allogenic or xenogenic cells. So we thought of ways to, regardless of cell source, could we actually generate a device or ways to prevent these cells or transplant the cell from the immunological attack? So we actually created these cells, cell population, and then coated with the cells with the having a positive polymer and negative polymer, and cross-linking them. This actually allows them to assemble onto cellular membrane, outer membrane, and it can actually it forms a 150 or 140 nanometer thin layer of the nanofilms. And we actually did some study where one of the polymer is positive charged and one of it is negative charged. So if you do positive, negative, and do this as a polymonophenol compound, which actually you can cross-link with the enzyme, okay, it actually forms a very stable thin film like a glycocalyx on a cellular membrane. You can do single cells, or you can do the on a spheroid. So we actually created these Min-Koo cells, which is pancreatic beta cells having organoid models, and label them with the six layers of these polymers, okay, that responded to glucose level insulin, and they were very stable in vitro. And we actually, once you have these islet cells, coated with the stabilized, they can actually, the membrane or the film can be stabilized. And one of the great advantages is that if you centrifuge the cell cluster, okay, with the 1000, G, these cells disassemble, but however, when we actually coated, created this stable film, they were able to maintain their shape. And they were even actually, physical barrier was actually provided by preventing the NK or natural killer cells to be attacking these inner cells, and they were able to maintain their shape throughout the period of time. So, and another thing is that, with this type of, film coating, we were able to show that with the native cells, with the NK or K562 cell, which is actually lymphomablast, okay? If you co-culture them with the NK natural killer cells, these would bind and natural killer cells would, provide, would attack and induce apoptosis of the K562 cells. However, if you coat these K562, the lymphomablast with this our technology with technique, the NK natural killer cells will not bind to it. Okay, there's a binding efficiency significantly reduced, and then when we expose these cells into the with the immunological cells, the cells will not be able to infiltrate. Okay, so we can actually have created this barrier. Okay, on a beta cell period for the long-term, effect in the in vivo environment. And we did actually do the transplantation of these cells into kidney capsule of mouse, immunocompetent models, allogenic model without any immunosuppressant. But then, the cells that were actually coated with the stabilized coating, they were able to reduce after, STZ treatment in a hyperglycemic state. After transplantation, the glucose cells, the insulin cells, the beta cells were able to reduce the glucose level to the normal glucose level. And when we performed the nephrectomy, the glucose level spiked up, indicating that the glucose control was actually performed by the cells that we transplanted. And when we performed the histological analysis, the transplanted cells were actually viable and were able to produce insulin for after long term. So, for us, we are actually concerned, like we have technology now where we can actually provide a stable, coating on a cell for the organoids. And when I prepare for this slide, I also kind of surprised the technology using the chimeric animal models, okay, as an organ incubator. So one of the examples is that, so we need to have either for us, for previous study, we thought of using simply the xenogenic or from the islet cells from the pig, and utilize them. But then, there are actually other studies where they actually created these transgenic pig models. Okay, this pig was engineered so that it do not actually, it do not make any specific organs. For example, this, you can actually engineer a pig that can, where it would not, make the kidney. Okay, so you can have a human cells make into iPS, okay, and inject these human cells into the, the embryo of pig embryos, okay, and if these human cells can contribute to a kidney structure, okay, this so, and survive, this, kidney, the pig would survive. What happens is that this kidney, the bone, surviving pig would have a human-specific, humanized organ in their body, so they can be harvested and transplanted into the human. So it's actually, I'm part of the Seoul National University IACUC, and this is whether this type of study is ethical. I mean, we can think about the regulation, the existing law, but there's no law that actually oversee these new technologies. So when we're concerned about the ethical ways, I mean, laws always are behind. Okay, if something happens, law would follow. So as a research scientist, okay, as an engineer, I'm trying to replace something for the benefit of human health. Certain strategies may not be ethical. Okay, maybe ethical. I don't know. In future, 10 years later, this could be one normal strategy for the organ transplantation. But there's no law that actually governs this type of research at the moment. So the burden is on the I guess the research scientists to provide the ethical ways to perform and provide a genuine data that can provide the get an approval from the public that this is a norm or ethical ways to perform and perform a research. So and there's a study recently about 9 years ago on the generation of chimeric rhesus monkey. Okay, so this is actually getting a chimeric with the human cells, okay, into the blood cyst of the rhesus monkey, and they actually generated these chimera. So what happens is that you have this generation of chimeric rhesus monkey that has a human tissues. Okay, so now it becomes a questionable, concern, like having a non-human primate models, having a human cells incorporated, okay, and this could be as close to human we can actually get, okay, and what would be the future direction of such a research that we need to actually have a deep thought and ponder upon, because there are many patients who need organ, okay, if this is the only way, then be it, but then you need to have I think as a scientific field, especially the Korean Academy of Sciences, I guess this is some of the the issues can be raised and discussed over this symposium. So conclusion is that tissue engineering has emerged as a solution for the organ replacement, but then initially it was actually based on the laboratory made, but then as we go on and look for the alternative cells, we actually saw the benefit of pluripotent stem cells or iPS. But then regarding primitive cells, early there's ethical concerns, but now it's not anymore. But then when you think about the organ level transplant, there actually still no regulation on the chimeric animals, okay, as an organ incubator, and what would be the future direction on this type of the research and clinical application of them in the clinical setting. All right, thank you.
Okay, thank you, Professor Hwang. It's a beautiful presentation that lead us into the current status and the future of the regenerative medicine. And I think there is a lot of the discussion point in an ethical perspective, but because we decided to postpone all the discussions at the end of the session, we will talk about that later. And take a deep breath, and please introduce the next presentation.
Thank you so much. It's my privilege to introduce Professor Byung Kim, who's the Professor of Hematology and Division of Internal Medicine and Department of Anatomy at the Medical College of Korea, Korea University. And his research field of interest is developmental biology of hematopoiesis and hematologic malignancies, as well as human research ethics in translational medicine. So he graduated from the Medical College of Korea, Korea University, and MD degree in 1990, and then a postgraduate degree in 1996 at the same university. And he also received the MPH degree from the Korean University in 2002. So let's welcome Professor Byung-Soo Kim.
Thank you. Thank you for the kind introduction for me. And it is my great pleasure to attend this meeting and have a chance to presentation. The topic of this session is the challenge and response for human research, protection of translational and clinical research in the area of post-industrial revolution. I will present this topic based on the written draft for the correct delivery of my meaning. The contents are as follows. Firstly, the concept of translation and clinical research is as follows. Types of knowledge produced is the technological application, that is technology, and the motivation is the solving problems. The key question is that does it work? Is the practical application of the product of research, and the objective is to come up with the solutions. So there are many concepts for translation and clinical research, but basically the translational and clinical research is composed of early translation, later translation, dissemination, and adoption. So, as stated above, the objective of translation research is to come up with the solutions. So, the standard for translation research to come up to reality is needed. The concept of GLP, good clinical practice, was established for bench work and animal experiment. The concept of good clinical practice was established for the research of human subjects. The concept of GMP, good manufacturing practice, was established for the commercialization of research findings. The concepts of GLP, GCP, GMP are co-current around the world. In other words, translation research must be done on the basis of international standards, which involves ethical guidelines. So, the objective of these international guidelines is to cross the valley of death between basic research and commercialization of research products to meet clinical unmet needs. So, the majority of the subjects in translational and clinical research are human beings. Human research protection in the study is very important because the participants are not only the sole subject of research, but also independent beings with dignity. As a result, systematic human research protection by way of IRB and HRPP is activated from the late of 20th century. ICH mission is to achieve great harmonization worldwide to ensure that safe, effective, and high-quality medicines are developed and registered in the most resource-efficient manner. Harmonization is achieved through the development of ICH guidelines by a process of scientific consensus with regulatory and industry experts working side by side. ICH guidelines composed of two subjects, quality guideline, safety guideline, efficacy guideline, multidisciplinary guidelines. GCP is involved in the FPCT guidelines. E6 is the good clinical practice guideline. And the details of GCP guidelines are obtainable in the homepage. And the sub-items of ICH GCP guidelines are as follows. What is GCP guideline? GCP guideline is a good clinical practice guideline, not great cash prize golf club president. As you know, this is the period of post-industrial revolution. The first industrial revolution composed of the utilization of energy and information. That is R&D based on energy and information is routinized in this period. So in this period, the top 10 scale, one top 10 scale is presented, and the highly 1, 2, 3 top 10 scale is compressed problem solving, critical thinking, creativity. That is the main component of R&D. R&D is the main weapon for survival in this period. This is shown that in America, high-cost job is high-end job is physician, lawyer, and R&D manager. That is, R&D is the main, very important in this period. In this period, telemedicine is routinized. So in medical area, the R&D is very important for survival of the doctor. So in this period, human research protection is not part of the property but a common virtue of R&D in this period. To now, it looks like that the sharing of human research protection concept is limited in medical R&D area. It is not fully spread to all areas of the science associated with human welfare. One of the examples is a common rule definition of human subject. Living person is a source of data through direct interaction or intervention, or living person is a source of private information and really readily identifiable. Secondly, the second challenge is the dramatic development of human research in this area creates a gap between the science and the ethics. The development of scientific means such as genomics, stem cells, and big data in the 21st century calls for a revamp of research ethics in the 20th century. It is like that the development of transportation raised the need for the enhancement of the Road Traffic Act. The guideline for human research using advanced science and technology on the practical application of the underlying concept for human research protection appears to be still insufficient. The example is the potential risk of genetic labeling, such as loss of insurance or employment, stigma, and unnecessary treatment. Lastly, the overall based growth logic and the policy overlooks the importance of basic ethics in human research, leading to increased possibility for distorted scientific development, result in inappropriate consequences, inappropriate results. It is a pity that the importance of research ethics based on human protection is in danger of being neglected in the name of regulatory reform. The examples are Dr. Hwang's scandals, Imbosa accident, Jesse Gelsinger investigation, and so many accidents are present in this period. One of the examples is Jesse Gelsinger investigation. The overviews are as follows. The problem is the failure to adhere to the stopping rule and the failure to adhere to the principle of informed consent and the failure to keep adequate record regarding vector lineage and titer. And lastly, changing the protocol without approval. So many dilemmas are present in this period in the research of translational and clinical research. So guidelines will be needed. So the response for challenges as follows. Personally, I think that the constant effort to spread the proper concepts for human research protection to all of the scientists dealing with human beings and human-oriented products, and to develop the guidelines for human research protection in the studies using advanced science and technology, and to deduce policies to promote R&D based on human research protection will be needed. So this is the picture for the academic medicine So I think that the concept of academic medicine will be needed in translational and clinical research. The concept of academic medicine is the scientific performing on the basis of ethics guideline. Thank you for your kind attention.
Thank you. Thank you so much for wonderful talk, Professor Byung-Soo Kim. Okay, we'll hold the question and answer until at the end of the session.
Okay, we are a little bit ahead of schedule, but I think it is good to go on. The next presenter is Professor Ok-Joo Kim. She is a professor of Seoul National University College of Medicine and director of the Center for Human Research Protection, Seoul National University Hospital. She is also chair of E6 Committee of the Korean Stem Cell Center while leading the EL5 ELSI project in stem cell research in Korea in collaboration with various governmental agencies and academia. She has worked for rebuilding research E6 system and promoting research E6 education in Korea. She has been serving for various committees in Korea, including Korean National Bioethics Review Committee, expert committee since 2005 till present. As an expert in biomedical research ethics, she participated in the Operation National Bioethics Policy Institute and implementation and the vision of Bioethics and Safety Act to expand its coverage from embryo to genetic research to the human participant in 2013. She served a member of the International Bioethics Committee in UNESCO to 2016 through 2019, and is currently a member of Korean National Commission for UNESCO. Professor Kim, you have 20 minutes.
Thank you very much. Good afternoon, ladies and gentlemen. This is my honor to introduce you about the infrastructure for biomedical research ethics in Korea. My talk will focus on IRB and HRPP. For last 20 years, there were rapid growth of clinical trials in Korea. This chart shows you how the Seoul become the number one of the clinical trial center in the world. This is 2007, and then it's increasing from rank 12, and it's if you see it's increasing, it's up and up, and then 2012, the Seoul is the most competitive city for the clinical trials of pharmaceutical product. And this on the left, it shows the geographical distribution of clinical trial institute certified by the Korean government. And among the 184, the 57 is in the Seoul. And then the right chart shows that South Korea is the first in number of industry-sponsored drug trials in Asia-Pacific in 2016. And I think this chart shows graphically how we changed in terms of clinical trial enterprise. I mean, many of you have lived through this period, right? So in 1998, there was no international clinical trial. And then 2000, we introduced ICS-GCP. And from that year, there's number 5 of the multinational trial. But if you see the 17, almost 300 multinational trials are conducted in Korea. So if you see this, there are several interventions or efforts of Korean government as well as pharmaceutical industries, also many medical scientists and clinical trials in Korea. I know that several of you here also participated in this progress. But my point is, against this backdrop, I want to show you how biomedical research ethics in Korea changed. So I put the title Beyond the IRB. You know that all what the IRB means, Institutional Review Board, and HRPP, Human Research Protection Program. So like USA, Korea started with IRB, but then it expanded into HRPP. So I want to take my institute, Seoul National University Hospital case, to show you the changes that we had in the last 20 years. This is SNUH, IRB, and HRPP history. And I'm very honored today that I'm with Professor Byung Park because he invited me to do this job from 2004. Actually, he was with from 2001 to this whole process. And I was actually, SNUH established IRB 1993, but it was not that good. So I was hired 2004 as an assistant professor, and I worked with Byung Park with task force to develop our IRB SOP into the global standardized form of the IRB SOP. And then next year, we had USA FWA, OHF registration. And then we got FORCAP first recognition. FORCAP is Forum for Ethical Review Committee in Asia and the Western Pacific. It's related with WHO activities. And then you got the eIRB system. And 2011, we initiated HRPP, and then we established Center for Human Research Protection Program, HRPP Center. I will call it HRPP Center. And then we changed the whole IRB SOP into HRPP SOP version 1 next year. And then we got through the AHAP accreditation process. And then we passed first accreditation. And last year, December, we had third AHAP accreditation. So what's the main difference between IRB into and the HRPP? Before IRB only system, when we had only IRB system, there was one domain, IRB. And then when we changed into HRPP system, we are required to get AHAP accreditation. The organization, for example, Seoul National University Hospital itself should be involved, Human Research Protection Program, and then all the researchers, research staffs, as well as IRB members, should be involved in the HRPP program. So before 2011, we just have IRB SOP, but we changed, expanded the SOP. First organization, second IRB, and third researcher. So we expanded into HRPP SOP. This is the organization chart for HRPP Center. The HRPP, I think it's very important to have IO, institutional officials. So in our case, the institutional official is the president of Biomedical Research Institute. So he or she is the vice president of the research in SNUH. And as before, IRB is the independent board, but we have to have conflict of interest committee to become our HRPP organization. And then we had Center for HRPP. I have been director since 2011. And there was 3 divisions, compliance assistant, regulatory, education 2-step, and QA auditors 4-step, and IRB administration 9-step. So if you see the changes of our institute, when I worked 2004, there was 2 panels, but the panel after recognition program, we changed into 4, 3 to 4, and then after center established, we made panel 8. And then the manpower also increased. When we had IRB only system, I had staff 3.5 person. But when I established the HRPP Center, the CEO, president of the hospital, gave me 8 more people, and now I have 15 full-time expert staffs. So this is quite, because of the expert recognition accreditation program, then we need to, and we have to get improved in order to meet the criteria. So it's very wonderful experience for us to have a better system. So this shows the HRPP activities in Seoul National University Hospital. IRB office manages many things, and education and training division also maintain all the activities of the education training. And regulatory affairs, they update the regulation, and they also check the compliance matters. And the big difference is QA, Quality Assurance Unit. When I heard my Japanese colleague from the beginning, he mentioned about the audit and monitoring, and that this is a big difference, even a big difference between other researches and biomedical researches. Biomedical researches, we are very used to get monitored, inspected, audited. But before 2011, researchers just submit the application, and then they get approval, and then they go away, and they never come back. But after HRPP, we send the people, auditors, to almost every researcher in the place, their research place, and then see whether they get informed consent the right way, whether they they perform very well in terms of inclusion criteria, exclusion criteria, whether they get every information in, according to their protocol. So their protocol compliance is going to be checked. And also we have participation help desk. So participants or any other people can call us. Then we will handle those complaints. And also we have conflict of interest administration. So if you see the chart, we only have 2 before IRB review. And that's all. So people worry about the rubber band. Do they have just approval stamp and wait away? No. Now they have to have education and training record in order to submit to IRB. And then they will get post-approval monitoring. And then with the result of post-approval monitoring, they will get education. So my main job is that if they have found something in the monitoring or auditing, I am the person who have special education to the research team, which have some non-compliance and matters. So it's very interesting. Even your medical big cheese or medical school dean or however you're high in your field, if your team had some problem with research ethics, you got to have special education or you will be out of these research activities for a while. So this is the system that you have. After audit finding, reflecting those things, we collect those findings, and then we do educate again. So we hope that this system will level up the scientific, ethical, legal standard of our researchers. And where did it come from? It come from the IOM, like 의학한림원, the equivalent organization, National Academy of Medicine in Korea. Professor Byung talked about the Jessica Singer's deaths in 1999, and several others died the very end of the 20th century. And then people began to realize how fragile is the IRB system. So IOM and other important parties, such as National organization of medical universities, medical colleges, and they all contemplate what's the problem. Because IRB system started 1970s. And for 30 years, they practiced IRB, but it's failed. People died during the clinical trials and clinical research. And so that awakened people. So IOM make a report in 2002, and they introduced new concept, Human Research Protection Program, with the responsibility beyond IRB. And then the AHAP, Association for Accreditation of Human Research Protection Program, we call it HRPP, accreditation body, this is non-governmental organization, advanced this operate of the HRPP concept. So Korea, Samsung was the first to apply the AHAP accreditation. So they got AHAP 2006, and 8 in total out of 257, they got AHAP accreditation in Korea. When I visited there 3 years ago, I heard from the AHAP people that Japan also prepared for this AHAP accreditation, but I don't know, so we can ask the first speaker. And then this is a history of my hospital. But if you see the general history of IRB and HRP in Korea, first we introduced the KGCP, it's 1995. And then the ICGCP leveled up, and then ICGCP got introduced as KGCP in Korea 2001. And with Byung and Sung-Jin, we established Korean IRB Association 2002. I mean, to prepare this slide, I went to the WHO website, and there I found my report to the WHO that in English, I reported to WHO that we established KIRB in 2002. And 2005, Biomedical Safety Act was enforced, and we had worldwide big scandal, so-called Hyesook scandal, and that changed the whole scenery of Korean research ethics. So through this series of change, we got the full revision of Biomedical Safety Act in 2013. I got involved in this whole process. And then 2014, Ministry of Food and Drug Safety of Korea issued guidelines for clinical trial participant protection program. Actually, this is HRPP, but Human Research Protection Program, they call it Clinical Trial Participant Protection Program. So it's the same one. So they issued, Ministry of, it's equivalent to US FDA, right? US FDA, think about US FDA issued guideline of HRPP. And then the next year, MFDS issued regulation training and designation of educational institution for clinical trial workers, which is really something. I know that you all got this training because of this regulation. And then 16, MFDS introduced the clinical trial subject, HRPP certification program. So we had very strong government-driven HRPP system. So I was quite surprised to get commented. This is the first government initiative adoption of HRPP in the world, because AHAP is the non-governmental organization. So its HRPP system is just self-regulatory businesses of academia, like IOM or like this academia. But Korea Ministry of Food and Drug Safety, they issued this HRPP guideline. And then you have two separate systems for MFDS approval research, like NDA and IND, this kind of thing. For marketing approval, you had MFDS GCP act, like a device trial act and pharmaceutical trial act, like this. But non-FDA-related human subject research, we have another act, which is Bioethics and Safety Act since 2013 until present. And interestingly, this whole change of the act expanded the concept of IRB. I mean, before 2013, the old concept, they changed into HRPP. If you see, the first one, it says IRB shall take charge of the following affairs. So first one is deliberation. That means review. Deliberative ethics means review and make a decision of the research. So first one was the function that the IRB used to do. And second is inspection and supervision of progress and outcome of the research. That means audit, monitoring, inspection. So it involves the QA activities, audit activities, and it says following activities the IRB must do it, which is education and protecting vulnerable subjects and establishment of ethical guidelines. So, like our HRPP Center, certainly not only MFDS, but also Ministry of Health and Welfare also expanded the IRB concept into HRPP. And according to the Act, when it was first established in 2005, it only had function to review genetic research and embryo research. And after the full revision of bioethics, it mandated IRB for all human genetic research and human material research in Korea, regardless of the funding. And also, it extended our function to include HRPP, as I showed to you. And it says IRB in Korea should be registered, evaluated, and accredited by Ministry of Welfare and Health. So this is accreditation mark. So they, after 2013, 2014 to last year, they have the 6 year of preliminary exercise of this accreditation. And then from this year, they will do real accreditation process in this year. So Korea is a very active country. They change it very rapidly. And if you see the MFS side, as I told you, they have 14, 15, 16 series of guidelines. And then this shows that, and they linked the 2 and 3. So only HRPP accredited hospital by MFDS, they can become a designated educational institute. Very complicated. So, this is an open database system. So this is the guideline that I told you. And then 14 HRPP guideline by MFDS, they set the HRPP-based component. First introduction, second is internal audit, QA, help desk for the research participant, and COI management, SOP management, and non-compliance management and education. And this, I think you are familiar with this. So the regulation issued by 2015, pharmaceutical law, all the clinical trial workers should finish the whole legally set the process of education and training. For example, if you are an investigator, you have to finish 8 hours. If you are research coordinator, you have to finish 40 hours, then you will start. And then this education program, you cannot go anywhere. The education center should be the center, HRPP certified accredited center, and then their whole education program should be certified and approved by the MFDS. So we had a lot of education program, and then this should be refreshed every year. What will be the current challenge of Korean system? I was asked by MFDS, we want to establish HRPP, nook and cranny of the Korean Peninsula. Yes. And then, what is the problem? Why is it so hard to make HRPP? So they have very strong will. And then they asked me, what is the problem? What is the problem? What is the problem for introduction and establishment of HRPP in Korea? So I visited Jeju Island, from Jeju Island, Gangwon, and every nook and cranny, which means certified clinical trial institute. And then I have regional meeting and then interviewed, and then I found out that Gangwon, Jeju, even they are very hard to hire nurses, not the research nurses, just nurse. And if in a biggest hospital in Jeju, if I said, oh, you're clinical oncologist, you are out. You have to stop your clinical trial because you have this is non-compliance. And then there is nobody who can conduct that clinical trial in that island. So the infrastructure is quite different from Seoul area, Big Five. And so I found out the challenge is that currently the institutional burden from the viewpoint of the site, research institute, they feel that they suffered from the duplication of separate education and certificate system, the two. I told you that we have very strong program, MFS, MFDS, HFP evaluation and certification program, and also Ministry of Health and Welfare have IRB evaluation and certification program starting this year. And there's two separate law, Pharmaceutical Affairs Act and Bioethics and Safety Act, and then they wish to integrate and make a linkage between the two acts. And so I recognize there's a wide variation in clinical trials in size and the operation system of HRPP. And then the private big hospital in Busan area or other area, the CEO's mind, the clinical trial is not their first concern. And also the quality of and ethics of clinical trial is not their concern. Their concern is to make a good revenue, good income to sustain this national health insurance system. So there's no incentive to hire people for the HRPP system. So the quality, HRPP concept of quality is that the quality should have the input of personnel's expertise and money, things like that. They need investment, but there's no incentive for the investment. So I make a very deep think and discussion with people. So the problem of lack of resources is the real problem. And the small organizations, IRB officers, perform the function of HRPP. So I recommend MFDS. HRPP accreditation program should be encouraged to non-tertiary hospitals by taking small step size into consideration. So there's need for customizing organization operation of IRB and HRPP. So we made several models. There are PRIMA conference, AHAP conference in the United States, and there is a special track, a small institutional track. So there are only one IRB members. What IRB steps? So what will you do to have HRPP? So we try to encourage, even you have one or half step, you can do these things. So this is the idea that you are not just doing development. You have to see the education, and after approval monitoring, you can do, I mean, you don't have to do everything, but you can select based upon the risk-based approach. So we make this Tae-Hwan. And also, like if you have more resources like Seoul National University Hospital, you can do separate center. And then if you are going to Gyeongbuk or Jeonbuk or it's not, I mean, the Seoul area, there can be a centralized HLPP system. Like, for example, Gyeongbuk area, if there is a center for HLPP, they can support the audit or education. So you can use centralized model or corporate model. So it can be shared, the regional HLPP resources can be shared. So we make some modeling. So conclusions.
Well, please hurry up.
Oh, yes.
Oh, okay.
Yeah, it's a conclusion. The strong leadership to promote HLPP by the Korean government can provide a critical opportunity to improvement of clinical trial participant protection and quality of clinical trial in Korea. Even though it's the world first case, I think it has very good, strong point. And for the clinical research, internal audit, this is a result of the survey study by KLB. 2019. Internal audit is the most effective and sole method of protecting safety and right of human research and integrity in Korea. So for this reason, regardless of the size of the institution, an internal audit should be enforced. The necessity of KLB and MFDS to improve HLPP awareness by advocating and educating the concept and necessity of HLPP in clinical research is very important. Thank you very much for your listening.
Thank you.
Well, thank you very much. And the last presentation for this session is by Professor Hyesook, Professor of Seoul National University School of Law. He primarily teaches areas in law and economics as well as in data privacy and artificial intelligence law. He currently serves as the president of the Asian Law and Economics Association, President of Korean Association for AI and Law, Director of SNU Asia Pacific Law Institute, and Associate Director of SNU AI Institute. In 2017, he launched the SNU AI Policy Initiative and currently serves as its co-director. The title for his presentation is Data Privacy Issue for Record Linking Research in Korea. Professor Ko, please, you have this mic.
Thank you. Thank you for the nice introduction. I'll talk about data privacy in Korea. So my talk will have two parts, basically. First part is about general scheme of data privacy in Korea, and the second part more focused on medical research. In Korea, data protection law scheme is more kind of generalized law in the sense that we don't have something like HIPAA in the US, HIPAA. In the US, we call it sectoral approach, and there's a separate law in the US covering health and medical data. But in Korea, there is no such separate sectoral law covering medical data. So we have general law covering data privacy, and we need to apply that law to the medical and health area. So, from, say, the past 10 years or so, we have been talking a lot more about data, and we are talking even more about data. So the key question is how to make useful data available for research, and at the same time, how to protect data privacy. And in particular, during the several past years, machine learning has been used more actively in many areas, including medicine. So for in order to do research in machine learning, you need to have a lot of data to be used for training purpose. So we have been, in Korea, we have been talking about how to make data available for whatever it means. So I listed several methods or approaches that have been taking place. First of all, try to amend the law, data protection law. You know, every National Assembly session, there are proposals to amend the law. Even this year, there are pending proposals to amend the law. In every National Assembly session, you can easily find at least 5, maybe 10, 20 proposals to amend the law. The second way is to de-identify personal data. I mean, personal data is, by definition, data which enables identification of an individual. So the very simple proposal would be, what about making data not identifiable? So why don't you de-identify personal data? Then, you know, by definition, such data will no longer be identifiable, and as such, it will not be subject to data protection law. So I'll talk about that more in detail. And the third, why don't you compile data sort of as a public asset and make them available? For instance, data held by National Health Insurance Scheme or Health Insurance Review Agency, you know, can possibly be viewed as public asset and ask them to make the data available. And fourth, we have been talking about a scheme called My Data. So that's more kind of giving control to individuals. And fifth, that's somewhat different, but you know, in the EU there is a general law called GDPR, and they have requirement for adequacy assessment, and have been trying to get adequacy assessment from European Commission. So this slide shows the scheme run by National Health Insurance Service. Perhaps many of the audience here or through the internet are already familiar with the scheme that they run. And basically, for this purpose, the National Health Insurance Service, they provide data to researchers in two formats. One is called cohort data, and the other called customized data. Cohort data is more kind of standardized data. There are several kinds already. And by cohort data, it almost by definition means data that has been rendered anonymous. So they have been very careful to build up the data so that the data itself represent the whole population in terms of statistical analysis. At the same time, they try to make it anonymous so that nobody can be re-identified analyzing the cohort data. With customized data, conceptually there is higher risk of re-identification. So data itself has higher risk in terms of data privacy, and to compensate that or to make up, you need to visit their research centers, and you have to conduct research on premise. So they have, you know, you can possibly get data with higher level of utility, but at the same time, the procedure could be somewhat more cumbersome. So overall, you know, you will get manageable level of privacy. So about the identification of data, the Korean government tried to address by issuing a guideline, and that effort in earnest started in 2016. In 2016, the Korean government, several government agencies together issued guidelines. So the general scheme is what you see on the screen. You have personal identifiable data, you de-identify, and then you get review or assessment by expert board. So the key concept there is what's called K-anonymity. So you set a certain level of anonymity criteria, and you render your data anonymous, and then outside expert board would make a judgment. And there has been controversy with this scheme. The key part was once you make the data anonymous using the concept of K-anonymity, could that be considered anonymous under the law? And there is also the scheme to combine two different data sets. And again, when you combine two different data sets, the concept of K-anonymity will still be applicable. I assume audience here is familiar with the concept of K-anonymity. Basically, K-anonymity means there are K records in the data set showing the same quasi-identifiers. And some of the NGOs, they've made press releases and other protests, and then finally they filed a complaint, criminal complaint. In Korea, violation of personal data protection law, some provision would be subject to criminal charges. So, with these criminal charges, many agencies, they were very reluctant to follow suit with the guidelines. So then they began to talk about amending the law. And in the EU, they promulgated the GDPR in 2016, and from 2018, GDPR became effective. So GDPR actually had influence, and so that kind of gave impetus to amend the Korean law. The Korean law, there are several different statutes. The main statute is PIPA, Personal Information Protection Act. That's PIPA serves as sort of general law. And the scheme is very simple. You define personal data, and if you want to collect the personal data, you need to get consent. If the law has such a simple scheme, if it's too simple, perhaps there is a problem, and there was indeed. And there are other laws, IC Network Act, Location Information Act, Credit Information Act, and there were, we began talking about amending the law around 2018, and that's when in Europe GDPR became effective. So about de-identifying data, it's kind of seeing a glass half full. Some people say it's, optimistically, there's enough of water, and pessimists would say you only have half of the water. And so pessimistic view is even if you de-identify, somehow someone with right skill or luck would re-identify. And pragmatic view would be you cannot guarantee like 100%. That's unrealistic. But at the same time, with technique, with procedure and control, you can realistically achieve what you want, which is rendering the data not identifiable. As I mentioned, GDPR was passed and became effective. And what was discussed a lot in Korea was the concept of pseudonymization. I mean, pseudonymization itself has been used for a long time, but in practice. But in GDPR, there are explicit provisions introduced in the law. So this is the legal provision. And in 2018, discussions began about amending the law. And after about 2 years, early last year, early 2020, law changed. And a crucial part was the introduction of the concept of pseudonymized data. And once you pseudonymize the data, you can use for several designated purposes. One is for statistical purposes, and the second is for scientific research purposes, and third, archiving purposes. So for these three purposes, you can pseudonymize and use the data. Pseudonymization implies it still possibly be identified. So pseudonymized data is a subset of a usual regular personal data. And there are several agencies to be designated which should carry out data combination or linkage. In medical and health arena, there are 3 agencies designated last year. They are National Health Insurance Service and HIRA, Health Insurance Review Agency, and KHIDA, Korea Health Industry Development Institute. Due to the lack of time, I'll skip a few slides. Here, this slide shows the scheme under which different data sets can be combined. There are, say, in this scheme, 2 institutions, institution A and B. They want to combine data sets that they each hold, and they can then ask designated agency, for example, Health Insurance Service or HIRA or KIDI. And KISA is involved. KISA is Korea Internet Security Agency. And KISA's role is provide hashed key so that 2 different sets can be combined. And here, again, there's assessment process. And typically, outside experts composed of 3 individuals will assess the adequacy of pseudonymized data, whether that's properly pseudonymized and whether there's risk of re-identification. I'll skip that. And for the remaining few minutes, I'll talk about the medical data. The screen, it shows guidelines published by Korean Personal Information Protection Commission as well as from Ministry of Health and Welfare. Ministry of Health and Welfare issued a guideline in September last year and then amended the guidelines earlier this year. So they issued amended guideline in January of this year. And there they declare that it's about health data or data on health. And in PIPA, Personal Information Protection Act, health data is considered part of sensitive personal data. And says how to pseudonymize and use for scientific research. And at the same time, for some type of data, you still need to have consent. I mean, for pseudonymized data, you don't need to have consent, but the guideline listed some types of data which is deemed high risk so that consent is still required. There are generally 3 types. First type is when the data involves human rights or privacy issues. And the second is when pseudonymized data still requires some further safeguard. And third, when consent is required under other statute. And the questions could arise about the first category when issues related to human rights or privacy are involved, and they listed this data relating to psychiatric diseases, and second, data related to sexually transmitted diseases, and third, data related to rare diseases. That's for kind of identification risk, and the data related to age, and fifth, data related to abuse or abortion. So this is, generally speaking, related to concern on social stigma and that sort of issues. And about scientific research, it defines it pretty broadly. Scientific methodology is key, and it could include something for industrial purpose. So for development of drug, development for medical device, for treatment, and others. And perhaps many of here are already aware that the concept of data review board. Some hospitals already had on their own data review board, but the government issued guidelines explicitly requires to establish data review board, and it is to have at least minimum 5, maximum 15 members, and out of 5 to 15 members, there should be, say, a few designated members. First, somebody representing data subject, including patients or app users, and somebody who is an expert in medical data, and somebody who is knowledgeable on data security or privacy law. So I'm aware that quite a few hospitals are, having hard time establishing this data review board. So there have been a lot of concerns and controversy how to set up the data review board, how to establish the relationship between data review board and ILB. And this is the general scheme about pseudonymization. And pseudonymizing means removing identifying and substituting the identifier with something different. And the guideline says biometric data can be used without further manipulation. Image data, they either delete mask, and for DICOM header should be deleted, that sort of typical method. And for, say, surface image, say, for example, facial X-ray, you need to use surface blurring software, that sort of things. And for unstructured data, you still need to have consent. Examples are free entries, voice identifiers, or biometric identifiers, for like iris. Genetic data more or less need to have consent. And this is the last slide. Combination of pseudonymized data should be done by expert designated agencies. I mentioned 3 agencies that have been designated. And I'm aware that National Health Insurance Service has been doing a few projects of combining data held by different institutions. And transferring to a third party, that could be a tricky issue. Meaning, like, A gets data transferred to B, and then B transferred to C. That's that kind of transferring as a chain event. In order to do that, for example, B receives from A, then B needs to conduct its own research without doing research, you should not transfer to C. And it's understood that having that scheme is to prevent to have data broker, as we see in a few other countries. So this is very changing and developing area, and what I provide is kind of summary of what has been transpiring the past couple of years. Thank you.
All right, thank you. Thank you, Professor Ko. So at this time, I'd like to invite all the speakers to come up front, and it'll take a few more minutes for extended discussion. And we have Professor Kubota online, okay, and he will also join us. So if you have questions, and we'll be happy to have all this discussion time. So we'll come back in about a minute. Okay, thank you. All right, welcome to the discussion session on the biomedical research ethics. We have Professor Kubota online. Thank you so much for joining us. So this floor is open for questions. So if you have any question from the audience, we'll start. Otherwise, I'll ask Professor He may have a few questions to start.
Well, Professor Kubota, we heard your presentation very impressively. But I think during your presentation, you have emphasized that several guidelines have no superior law. Is that, in fact, I think that is provided by the Ministry of Japan. So, is there any reason why the old guidelines are prepared without making a basis for the law?
Well, I don't know exactly, but some guidelines have superior law, and the others do not have. I don't know exactly the reason.
The reason I ask is that if the government do not play an important role in making the guidelines and take actions in implementing those guidelines, the activities of the academic society is very important, or the other groups. So is there any apparent activities of the academic society to implement the bioethics in Japan?
Well, I'm not quite sure. honestly, I'm not really specialist on ethics of biomedical research. And yeah, making guidelines, many specialists on that area are involved, I think. But to make the guidelines effective, I think they require government to issue, even if it is not under the law. I think so.
Okay. The last question is that, based on your experience and the experience in Japan, what do you think the ethical level, especially in the biomedical research in Japan? And is there any comment or any suggestion that you can give to us, the Koreans, to make the biomedical research more ethical?
Well, in fact, I learned a lot today about the Korean situation, and I think the current situation in Korea is superior to Japan. Yeah, I have no particular suggestion or particular comments on Korea. Rather, I appreciate today's session where I can learn a lot.
Okay, thank you. We may be back to you if we have more time. Thank you.
So we have Professor Byung-Soo Kim. I have a question. You actually mentioned the Gaisling case from University of Pennsylvania that actually probably held back the 10 years of research in the from the bench to bedside. And from your concern, like when we try to make a clinical cases or clinical applications, it seems like the design of the initial design is very critical from the bench to a bedside type of clinical research. And how would you recommend, like, is there any from the Korean agencies? I'm sure there's a pre-IND meeting by Korean FDA, and it's like when the scientists are trying to design for the clinical related research, it seems like there's some help in terms of the the design of the clinical research. And then do you have any comments on like what would be the best, not ethical issues, but because ethical issues arise because the initial design of clinical research is maybe prone to failure in the beginning?
Because of distance and mask, I wonder that I understand rightly for your question. But I answer your question is that as follows. Research ethics might be applied science or regulatory science. So the cases associated with the real-world application of research ethics must be collected as a big data. So there are some data about these issues in the advanced country. However, in Korea, the data collection associated with this issue appears to be disappointing. So the effect for this topic must be emphasized. I'm sorry for the lack of interest in this field in our country. So the big data collection associated with the ethics guidelines or the accident associated with ethical problem must be collected rightly and used as a big data.
Okay. All right, thank you. And Professor Ok-Joo Kim, you mentioned the lack of resources in the smaller hospitals regarding the HRPP, and you have mentioned the forming a collaborative, the multi-center type of HRPP that could be one solution. What is the big, hurdle to set up that kind of system?
Yeah, I think the one very good example is Catholic University Association. They have a more separate hospital, but they have one HRPP and they share many resources. That's a good example. And then, for example, in Daegu has a Chambok center, and then they can collaborate. And actually, the issue is money and investment. Okay. So the local people, I mean, the local site asked Ministry of Health and Welfare or FDA, MFDS, why don't you invest money for HRPP? And then, well, we will give you incentive. We will incentivize you. So if you have certified HRPP, we will give you the right to educate HRPP people. So, you know, that is, I mean, it's very difficult for private hospital to draw money to invest those HRPP. So I think there must be public investment. And then I think National Academy of Medicine can, you know, propose that kind of, this is could
it be like a non-profit organization sponsored by government to actually oversee like HRPP in smaller hospitals? And probably, you know, the National Academy of Medicine could be actually, you know, selective in terms of, you know, which agencies to do that.
I think this, I mean, academy can be a strong voice to propose that.
Okay, thank you. And Professor Hyesook, you mentioned the data, the pseudonymization using the public data for the research in academia, and you mentioned the third-party use and how, you know, like providing a permission to third parties if they conduct research, and you know, so that they will not actually transfer to another party with some profitable outcome. And what would be the measure to retract those data once they are utilized? I mean, these could be, you know, once transfer this data to the third party and do the clinical research. I mean, these are now, you know, open for, you know, they can do, you know, what would be the measurement to, you know, do such a, you know, measurement?
That's an excellent question. Right now, there's no explicit provision. The duty is not, once you have the data, pseudonymized data, you do research, and somehow if you identify an individual within the data set, you stop doing research and you report it. And the real question would be, who would report, I did re-identify somebody, what should I do? Who would bring that kind of issue up to the compliance department or to the regulatory agency? So that kind of question is still out in the open.
Okay, I think I am asking Professor Hwang because he's also presented. He also had a presentation. Well, you covered two specific areas of the regenerative medicine. You did not, even though you did not mention about the gene therapy, you talk about the cell therapy and tissue engineering therapy. And you, based on your presentation, I think you are focusing on the tissue engineering. And what do you think is the ethical the issues that I mean is associated with tissue engineering, especially when you are doing the research with the human-animal hybrid or other transplantable the stem cells like wrapped by the nano films or.
So you know, to give a perspective, like you know, biomedical researchers, like when we see a problem, we try to solve the problem, and we don't think about ethical issues at the moment. That's the, I guess, problem that we face. You know, I'm sure with the clinical, you know, clinicians, you know, when they have a, you know, they will face the same thing. When you have a, you know, company-sponsored clinical trials, they will not see whether it's the drug itself is safe or not. It's just, you know, they're gonna, you know, prone to do it because of its, you know, it's you know, the all the you know, check and balance should be, you know, on the company side. So you know, as an example, like when we develop a product, okay, we have to go through probably clinical trials through IRB and HRPP and all these clinical regulation and ethical issues that we all would have to, you know, face. And the problem that we face is that, you know, when we you know, all these regulations, for example, like I understand that it exists, but then it could be, somewhat hurdle for, the researchers like this, like me, because when we try to develop a new product, okay, and the government agencies are, would only abide by the laws, and when we try to develop a new product, new treatment, and these may not be under the current existing laws, okay, so that's the problem that we face, and I guess, we can talk about the laws and ethics, for long enough time. But then, if you think about, these laws didn't exist, 20, 30 years ago, okay? And then, and many of the products that we are currently using have been developed, many years ago that where the laws, ethical regulation did not exist. So, I guess it's a check and balance that government has to be in place. And for example, as a researcher, I guess the education, HRPP type of education is actually necessary for us because we wouldn't have, I guess those type, those check and balance system is very critical in terms of for us because, we might be biased toward the our own goal to achieve therapeutic strategies.
Can I comment on that?
Yes.
I think in your diagram, there is a certain big barrier between animal research and then application of that product to human. That's a whole different story. So, of course, the regulatory agency has a responsibility whether you have to have a certain kind of preclinical data, things like that. But I think even those animal research period, I think we need to talk to the public whether it's okay to make chimera, chimera kidney. So I think I was so surprised today listening your talk because you can't. I don't think the scientists are hiding, but you have to be more active to discuss with the public.
Yes, I mean there are humanized mouse models, and people are trying to understand cancer. Mouse model doesn't work, so they try to have the blood system that actually compatible with the human, and that's actually been going on. I mean, in the current research area realm of the animal research, the genetically engineered models and then humanized models are evolving, and now they're in a smaller scale, and they can be going to the larger scales, maybe probably non-human primate. It's like we're actually, instead of using human, now we are using a monkey that's humanized and doing the exact same research. And can we see it as an animal research or can we see it as a clinical research? That's still some debate that we should, probably focus maybe in the future. Yes.
Okay, I think we should have more time for discussion, but it's almost time to finish up. And I think the second session should be closed now, and I would like to invite Professor Byung-in Choi, the chair of the organizing committee of the 47th KAST-NAMOK Joint International Symposium, for closing. Thank you very much.
Good afternoon, distinguished guests, dear colleagues, ladies and gentlemen. First of all, as an organizer of this symposium, I'd like to thank all of you for participating in KAST-NAMOK Joint International Symposium. Personally, I really enjoyed this innovative and impressive webinar with internationally renowned speakers and moderators in this afternoon. So I believe this symposium provided an opportunity to exchange recent knowledge and experience for all participants in the field of scientific and ethical research in biomedical sciences. I try to summarize today's symposium very briefly. Part 1, entitled Scientific Research, covered development and evolution of novel infrastructure, CCEB, for clinical biomedical research, linking epidemiology, biostatistics, clinical medicine, and health sciences in the USA. Importance of objective verification of scientific evidence for clinical practice, introduction to resource of the linkage of epidemiology data in Korea, and considerations in data linkage research, appropriate study design and data science technology, facilitating good biomedical research using healthcare big data with less time and cost for good clinical practice. Part 2, entitled Biomedical Research Ethics, covered chronological advent of regulations, guidelines of research ethics, introduction of good clinical practice, GCP, and need of comprehensive planning of structure of resources and law for public health and biomedical ethics in Japan, ethical concerns in regenerative engineering from stem cells to humanized model, and challenge and response for human research protection of translational and clinical research, explaining new paradigm shifts in the era of fourth industrial revolution, infrastructure for biomedical research ethics in Korea with the explanation of chronology of IRB and HRPP Center, and data privacy issues for record linking research in Korea, explaining generalized guidelines and health and medical data guideline. And lastly, I'd like to thank President of KAST-NAMOK, Professor Min-Koo and Professor Tae-Hwan Lim for their strong support for this symposium, and key organizing members, Professor Hoguen Kim and Byung Park, 4 moderators including Professor Yoon-Ok and others, and 10 outstanding speakers for sharing their knowledge and expertise with their outstanding presentations and discussion, and audience for their active participation for the success of this joint international symposium. Once again, thank you for your very active participation, and have a nice evening. Thank you.